Good morning, and welcome to the second annual Oncology360 event. As you gather here today, patients, survivors, families, caregivers, and colleagues, we honor the remarkable journey of cancer care at El Camino Health. Oncology360 is more than an event. It's a testament to the strength of our community and the progress we have made together. At El Camino Health, we are proud to offer cancer care that meets the highest levels of contemporary medicine right here in your community. Our cancer centers in Mountain View and Los Gatos deliver advanced diagnostics and the latest oncology and comprehensive support services. What truly sets El Camino Health apart is not just our technology or advanced science of medicine. It's the intangible magic within our people. Our nurses, our physicians, and staff bring expertise, compassion, and a relentless dedication to every patient and family. This unique spirit, this sense of family and hope, is woven into the fabric of our cancer program and is the foundation of the exceptional care we provide. Thank you for being part of our community, for supporting one another, and for inspiring us to continually raise the bar in cancer care. Together, we are not only fighting cancer, we are helping our patients live their best lives. Thank you, and welcome to Oncology 360.
All right. The struggle is real. I'm going to put my readers on. All right. Good morning. Can everyone hear me?
Yes.
Great. Well, good morning. I'm Tracy Lewis-Taylor. I'm the Chief Operating Officer for El Camino Health, and it is my privilege to welcome you all to this special day. I want to begin by thanking Dan Woods, our CEO, for his remarks and, of course, his unwavering support for our oncology program. Certainly, not only the program, but for the patients and the families we serve. Today is one of my favorite days of the year, most importantly because it brings together something that's truly remarkable. It brings together a community that's united by resilience, hope, compassion, healing, and most importantly, strength and resilience. Whether you're newly diagnosed or actively undergoing treatment, celebrating survivorship, or supporting a loved one, or remembering someone who's been impacted by cancer, please know this, that we see you, we welcome you, and most importantly, again, we're honored that you're here with us today and every day. At El Camino Health, we are deeply committed to providing exceptional cancer care close to home. Our oncology program continues to grow, which is something I'm really proud of. We continue to evolve, offering advanced treatment options, multidisciplinary expertise, something that you'll hear a lot about. We offer personalized care that supports programs and patients through every phase of their journey. We're really proud of the clinical programs and the expertise of our physicians, nurses, advanced practice providers, therapists, pharmacists, social workers, navigators. Take a breath, and the countless team members who work together every day to deliver high quality and compassionate care. But just as important as the clinical care that we provide are the supportive oncology programs. And again, you probably saw most of those programs here represented just before the program started. These programs really help address the physical, emotional, nutritional, financial, and spiritual challenges that can accompany a cancer diagnosis. This healing really extends far beyond treatment alone. And this really helps us to show that we are truly committed to caring for the whole person, not just that specific diagnosis. Before I talk a little bit about today's agenda, I really want to recognize and thank the El Camino Health Foundation for their extraordinary partnership and commitment to advancing care in our community. And one of the reasons why I want to thank the foundation and particularly our donors is because the foundation has really helped to make possible a number of important initiatives that have directly impacted our patients over the last several years. These investments have strengthened our clinical capabilities, expanded supportive care services, a lot of those that I've just mentioned, enhanced rehab and mental health services, supported our quality initiatives, most importantly, provided emergency financial assistance to patients who are in need. And really, one of the most important things, again, really helped advance the growth of our cancer programs physically by expanding locations in our Los Gatos campus and coming soon to a Mountain View campus near you. We'll be expanding services in the Mountain View location as well. This generosity, again, goes well beyond just treating the disease, but focuses on caring for the whole person. So again, we're deeply grateful to the foundation and our donors, many of whom are likely sitting in this room today. In the spirit of recognition, I want to thank and extend my sincere appreciation to the individuals who made this event possible. A sincere thank you to Dr. Shamli Singhal, standing in the back of the room, Jasmine Jose, and the entire oncology service line team, too many names to list here in this program, for their leadership, vision, and countless hours of planning. I also certainly want to thank our presenters who are sharing their expertise today. Today's symposium has been thoughtfully curated to provide meaningful education, practical resources, and opportunities for connection. The sessions are focused on the latest advancements in cancer treatment, supportive care resources, wellness strategies, and survivorship. I know that you will leave today feeling informed, empowered, and inspired. As we begin today's program, I encourage you to take advantage of the opportunity to learn. Please ask questions, connect with others, and explore the many available resources to you. Most importantly, I hope you leave knowing that you are a part of not just a community, but the El Camino Health family, a family that cares deeply about your health, your well-being, and your future. Thank you for being here today. Thank you for allowing us to be part of your journey. Welcome to Oncology360, and I hope you have a wonderful and a meaningful day with us together.
Okay, thank you very much all for being here. I'm Dr. Shamli Singhal. I'm a surgical oncologist and the medical director of the cancer program. I welcome you here today. This is my favorite day of the whole year, where we get to celebrate our people and our community and celebrate it with the doctors that take care of you. I wanted to just give you a moment of reflection, because we have been open for 21 years, our cancer program, and we started in 2005. And in 2005, El Camino was a general community hospital. We did not provide cancer services, and all of our patients had to come to the hospital. They got diagnosed, and then they got sent outside of our community. They got sent 20 miles away, 40 miles away, wherever cancer care was. And the vision of the directors in that time were that we bring academic level care to our community, so our patients and our community could stay in their community and get the best care possible. So that was the vision in 2005. And in 2005, we wrote the first set of business plans. The board supported it. And in 2007, December 28th of 2007, we saw our first patient. We started Silicon Valley style, one patient, one doctor, one chart, one nurse. Okay. So when we grow and you look around the room and you see all these amazing people here that have lived and worked in our community, and we have taken care of them with the best way that we could possibly do, then you will understand what we have built together, right? We built this together. We built it for each other. We built it around each other, and we built it for all the people that we love and that we care about. So think about it, congratulate yourselves that we are all here together to celebrate this day. And I will remind you of one thing that El Camino Health believes in, and believes in very strongly, all right? There's a disease, and we treat the disease, right? But there's an illness, and the illness is really the impact of that disease on your life. We want your life to be a success. And so our success is defined by you doing your regularly scheduled activities. Get back to what you were doing. Cancer will be a part of your life. It is a part of your life, but it doesn't have to be the whole thing. All right. And so when you see us treat you with medicines and things like that, think how valuable it is that we have all this support for you. We want you not to suffer from the disease that you have. We want you to incorporate all these other things that come with it. And we're here for you. We'll support you. We will be here for you because you are part of our community and you are part of our family. And we ask that you come back. We ask that you show us your success. We ask that you send us photographs of doing things. So in my own personal practice, my patients send me pictures. All right. So one of them decided to climb the Sydney Bridge. The other one went ziplining. The other one went to Tahiti on a boat. Okay. So there is a connection that we will always have together, but we want you to graduate. We want you to do things that you wish to do at all phases of treatment. So what you're going to hear today is going to be a glorious greatest hits of some of our doctors, some of our inventors, entrepreneurs, and looking forward onto the cancer care landscape and show you what's out there for you to experience and for you to look forward to. So again, I thank you so much for coming. I really appreciate that you took time out of your day to spend with us, and this will be a really amazing day. Thank you.
Thanks so much, Dr. Single. How's everybody feeling this morning? Wonderful. Okay, a quick introduction from me because it may explain why today is so meaningful for me. Some of you may recognize my name is Dion Lim. I spent 20 years as a TV news anchor and broadcaster across the country, and most recently serving here in the Bay Area. And I've spoken at so many of hundreds of events for so many different groups, but never did I imagine speaking at Oncology360 from the point of view, not as a broadcaster, but from the point of view of being a caregiver. Because my husband, Evan Panesis, who is sitting right here, please be kind to him. He does not do public speaking like I do. As someone who is a survivor of hairy cell leukemia. And this knocked our world upside down. So this is a little bit about our journey. As you can see on your screens there, we are the proud parents of an almost 3-year-old little boy. And the reason why it means so much to be here today is because we have 2 pillars that now drive every decision in our lives today. One is early detection, because without early detection, Evan would not be here today, and our son may not have a father. And 2, we believe so deeply in the out-of-the-box thinking from El Camino Health. And you'll learn a little bit about why this place is so incredibly special. And we trust our lives and the livelihoods of the people around us to El Camino. Now, a little bit about my husband and I. We are 41 and 42 years old, so relatively young by standards in this day and age. And we've been together for about 20 years. And we were the typical 20s and 30s travelers. We just assumed that life was for the taking. We traveled around the country. For my career in the Midwest and into the South, we traveled the country and the world on vacation thinking that nothing was wrong because we never had any major health problems. Truly, the extent of our preventative care was going to the eye doctor once a year, getting our teeth cleaned. Maybe we'd get a cavity here or there. And maybe taking care of our mental health on occasion, especially with the stresses of TV news and breaking stories. But the bottom line was that nothing was wrong. So why should we take those preventative measures? Of course, it's a hassle to go to the doctor, to get your blood tested, all of those things. But then everything changed in June of 2025. And it was a chance encounter at a most random place that flipped our worlds upside down. All we really wanted was a matcha. So trendy, so delicious. We needed that afternoon pick-me-up, so we went to our local matcha shop in San Francisco where we live, and we happened to pass by a place called Biohacker Health. And we just thought, oh, maybe you can get Botox there. Maybe you can get a vitamin injection. But a friend of mine said, no, you should go in. You should check it out. It might be fun. You might get some nice results of, I don't know, some vitamins, NAD supplements, all these things that I didn't know anything about, but would promise to make me look younger. Fantastic. So we took the blood test. Mine came back relatively normal. I had an iron deficiency, but that could be solved by taking supplements. My husband's, though, knocked us off our feet. It came back that he had extremely low platelets and his liver levels were very high. I didn't know what that meant. We were perplexed. After all, he didn't show any signs, any symptoms that anything was wrong. Evan, can you share with everyone? Did you have any signs of being sick or something being off?
Looking back, not much, but I did have some bruises that took a while to heal, and maybe a month or so they were just staying there, and I just figured I was getting older. And then I remember I did a swim one time, and just after one lap, I was pretty much out of breath, and again, I just thought I wasn't in the best shape, and at the time, I didn't realize anything was wrong, but
Yeah.
now looking back, we know why.
Yeah, and it's funny because this is an individual who has never smoked, does not drink, has a very healthy, relatively healthy diet. We do like cake on occasion. But it just seemed so confusing to us. And then the news came back, the beginning of the unknown. In July, Evan was then referred to a hepatologist, a liver doctor, and then also Dr. Shiva, a hematologist, who then provided care to us and explained exactly what these tests meant. It turned out that there would be a litany of tests and a lot of waiting, excruciating waiting, not knowing what was going to happen next. Why couldn't we get care sooner? But this was par for the course, and Dr. Shiva was there for us every step of the way. It turns out that my husband had a very rare form of leukemia called hairy cell. About 1,000 people across the country are diagnosed with this every year. So you can imagine how scary that was. And in fact, Evan didn't quite know what to do because life never teaches you how to deal with a diagnosis like this. Evan, can you share what it was like when you knew that it was go time, that your life was at risk and also the well-being of our families?
Yes, yeah, it's such a rare disease that not many places have experience with it, and everyone was telling me just to do chemo, and luckily I had enough time to do research online, and there's a lot of expert doctors out there that spend their whole career studying and researching hairy cell leukemia, and there's been some other protocols, one that I did that does not involve chemo, and luckily Dr. Shiva Singhal was open to it, and she did her own research and talked to one of the doctors that specializes in it, and and that's what I did, and I was definitely happy that she was willing to do that because if not, I would have to go to New York or New Mexico just to get a initial appointment, which seemed kind of out of the question at that time.
It was so daunting. I remember there were so many different options of what to do, but what was the right answer for us? Because obviously everyone's diagnosis is different. Everyone's life situation is different. And especially with someone having a family, a small child at home, we just wondered what would be the best course of action for the quality of life that we wanted to lead. Now, Evan touched upon this, but we had a hunt for options. Was chemo the right way to go? It was, for a very long time, the gold standard. However, many people who are diagnosed with hairy cell leukemia, we learned, are generally older, or oftentimes the diagnosis comes much later. Evan was so lucky to get that diagnosis because we walked by this biohacker health facility. Now, we found out that there was something similar to a clinical trial. Dr. Alan Savin, we have to give a shout out to, of Scripps Hospital Group in San Diego. He proposed this new protocol for younger patients like Evan. He also suggested that treatment could include a pill and a drug regime that was administered through an IV. So the options were find a hospital that was on the West Coast that would allow us to do this treatment. And the closest one that we could find was San Diego. All of the other options were on the East Coast, some places in the Midwest. We could not imagine uprooting our entire lives for the course of treatment, and also a very aggressive treatment where my husband would lose his hair. He would have all of the symptoms and the signs of going through chemotherapy. And this is why we are so incredibly grateful, and I am almost shaking at the thought of this, that out of all the hospital groups that we reached out to in the Bay Area that would allow us to live in our homes and to seek treatment close to home with our, at the time, 2-year-old child, to allow him to have his first day of school with his mother and father, was El Camino. Because no other hospital, no other oncologist would partake in this revolutionary treatment. It was Dr. Shiva, who is sitting here on this stage today, who took the time to not only speak to Dr. Savan about the methodology, but to do her own research, to have an open mind, and to understand that this was a viable option. She was confident. She gave that confidence to us. And in turn, we knew this was going to be successful in treatment. Treatment began on August of 2025. 12 hours of infusion biweekly, along with oral medication, lots of fatigue, lots of challenges, but still paled in comparison to what he would have experienced had he gone the route of chemotherapy. And today, we are so incredibly proud and to be here in front of you to officially say that my husband is in remission and is expected to live a very healthy quality of life. So with that, thank you all so incredibly much. I know Dr. Shiva is on stage to take some questions and to speak a little bit about her journey that she took. Thank you all so, so much.
So when I first met Evan, it was like he's a healthy young person who had been to a longevity clinic. And he was shaken when I said, you need this test. And I suspected this could be something bigger. But how do you tell a young 40-year-old, absolutely healthy, that you may have blood cancer? So that was the challenge I began with. The one thing in my heart, which I felt good, was this is a curable blood cancer. So I said, don't worry, we will go through this journey together, and which we did. And I did the bone marrow biopsy, and that was my biggest moment to share. And he lived in SFO. We are here. He has a little kid. To come here, to talk to me each time, and to get the diagnosis was very hard. And I don't like to give bad diagnosis on phone, so it was a very challenging time. Having said that, he came over, we talked about it, and I said, this is curable. But I have treated many. It is a very rare cancer. Not many oncologists get to treat even one. And I have done with cladribine. He is very brilliant, actually, and a youngsters that do ChatGPT, as you know, nowadays. So he had done his whole research. He's like, I'm not taking that. I'm like, even cladribine is a standard of choice. And you go to NCCN guidelines, this is what you get. He's like, nope. What about my secondary cancers? I'm like, we are talking cure with cladribine. And he's talking about newer data, newer things he has read up about. So he went, he did his very thorough research, as you listened to Dion. And he came back and said, this is what I want. And remember, this is a new generation kid I'm talking to. I'm not talking to somebody 80 years old who listens to me all the time. So this gentleman tells me, Dr. Singhal, this is the treatment I want. I don't want secondary cancers when I get older. So that was my challenge to take. So I did. I said, we go to secondary, tertiary cancer centers in our backyard. We have Stanford, we have UCSF, and he did. He did his thorough workup. But he didn't find anybody who would listen to him and listen to what he's trying to say. Why can't we do, he has a target called BRAF, why can't I do this regimen? So I said, okay, let me pick up the phone and talk to Dr. Savan. He's at Scripps and he's a pioneer of this newer study. I said, Dr. Savan, how many young patients have you treated? This gentleman wants to go with this regimen. He talked to me only for 5 minutes. He said, this is what I do. This is what I will do. And you can go through my study in ASH, that is American Society of Hematology, which I did. I did my thorough workup, talked to a few of my colleagues, and that's how the journey began. Today, here he is. He's in remission, 5 years, we'll call it cured, and he will be cured of this cancer. So that's a little bit of small journey, but definitely a cancer that is curable and is cured of one of the rare blood cancers.
Can I ask you a quick
Yeah, go ahead.
My quick question for you is, why did you feel like in this particular case you wanted to seek some alternates and learn a little bit more when so many others, why do you think other doctors were so regimented and did not want to listen? Because I think that's a frustration in healthcare oftentimes.
Correct. And I have to say something that as we grow in a field, we get experienced. And when we have experience, and I had the same thing when I met Evan, I was like, I've done cladribine, I've seen cure, we just admit we do the treatment for 7 days and you're cured. How do you come up with the treatment that you have not given, which is still not the standardized treatment? If you open NCCN guidelines, cladribine is still the standard. So how do you give a 40-year-old gentleman who's asking for that when you can see the cure? So that was one of the setbacks, and that is what the setback many young doctors have. Another thing is their ability to treat hairy cell leukemia. It's a very rare cancer. Very few oncologists get to even treat one in their lifespan of being an oncologist. I think these are the two big reasons I see. Even we needed to collaborate. That is the biggest thing I think I have seen, that we collaborated as a patient-doctor relationship, that collaboration and collaborating with the institution outside of El Camino, that we three joined hands, because Dr. Savan was with me throughout. I said, you're going to be there, I'm going to call you, and I want you to know that this is what I'm going with, but he stood with us as well. So that gave me a little bit of boost that I could, because it is a published study, it is something that has been proven, it has very good outcomes, and that will prevent secondary cancers, which is what I want. When we see young patients these days, we have to be more creative. We have to think about when they're going to live 100, they don't come up with a second cancer. So that is what my goal and reasoning for change was.
Thank you so much for that collaboration. It made all the difference in this case.
I'm really thankful for you both to be a part of El Camino family, and thankful that I could take care of you.
It's our privilege. Thank you so, so much.
My cancer journey I was diagnosed with breast cancer in January 2025, and my oncologist and her nurse practitioner referred me to the SPARKS program. That's about the time when I started looking at the SPARKS flyers that were out at the cancer center. And that's when I started thinking I could really use someone to talk to that understands people who are going through a cancer journey. The health coach gave me someone that I could talk to, and she also helped me set goals and even suggested what could be my goals if I didn't know. And then with her worked out a plan of things that I would want to do, and she held me accountable for that. I was able to think about, okay, I need to do this because I'm going to be talking to her again, and I want to be able to say, I did accomplish this. I really appreciated that there was someone to talk to and to figure out what comes next. I don't want to always think about, I'm a cancer survivor. I am. But I want to go forward in my life without thinking about cancer. For anyone who is going through a cancer journey, I would really recommend reaching out to the SPARKS program, because there are resources that you may not realize you have access to. And that is one of the things that has surprised me along the way. There are so many resources and so many things that have been set up so that you are successful at recovering from the cancer journey.
Hi, my name is Jasmine Joes. I'm the executive director for the cancer service line at El Camino Health. I see Ashish standing there. I just want to give you kudos for sponsoring the cancer health coaching program. So I'm honored to be here today with you all and moderating this panel with this wonderful panelists. I'm really privileged to be able to work with each one of them. Before I get started, I want to take a moment to thank Dion, Evan, Dr. Single for sharing that story. The message of hope, personalized cancer care, intertwined with creativity and innovation to make Evan's journey here, that's customized, personalized, is what makes El Camino Health special. The doctors, the staff, and all those who support the cancer program are truly dedicated to the patients, one patient at a time. So moving on to our panel here today, innovation has always been the engine that fuels leading-edge cancer care. Over the last decade, El Camino Health has brought cutting-edge cancer care to our patients in the South Bay. It started with El Camino Health creating the first electronic medical record in partnership with Lockheed Martin, to many other discoveries that were incorporated to bring excellence in patient care. So I'd like to take a moment to introduce our panelists here. So I'll start from the left. We have Andrew Cleland, the CEO of Fogarty Innovation, Dr. Priya Jayachandran, co-medical director of the breast cancer program, director of cancer research, and a breast medical oncologist. Dr. John Shumway, he's a radiation oncologist. Dr. Nels Carroll, a robotically trained cardiothoracic surgeon. So before we take a deep dive into our main topic, I want to start out with some fun facts about each of these highly accomplished individuals. I may embarrass them, but maybe not. They volunteered this information. So there is one individual here who was a teacher before they became a doctor. One majored in piano before going to medical school. Another one fosters cats with the Humane Society. And another who wears black elephant t-shirts to every single talk. And he has an interesting story if you want to catch him after the session. So we'll get started. Andrew, as the CEO of Fogarty Innovation, you lead an impressive collection of companies that are transforming care. The companies Fogarty Innovation incubates take concepts from benchside to bedside. Can you help us learn more about the Fogarty Innovation and how it brings cutting-edge cancer care to patients at El Camino Health?
Yeah, it'd be my pleasure, and I am honored to be up here in front of you all today. So I am going to tell the story, though, really quickly. I know, because I can see we got plenty of time. So it is this little shirt, some of you can see, and I'm going to take it off because it reminds me of what you just did, all right? And I also feel a little uncomfortable not having a white shirt. So if you can see on the back, a little Latin quote. That Latin quote is attributed to Hannibal as he was about to go over the Alps to invade Rome, right? All the way back there. And he was asked, how's he going to do it? And that quote is, it's all right, I can stay there. I will either find a way or make one. If that's not your story, I couldn't think of a better quote for you. To me, it is also the apt quote for El Camino, and particularly what you're doing, Jasmine. Always looking to find a way. If not, you're going to make it. It is the story of innovation. We, Fogarty, have an almost 20-year partnership with El Camino. I think that the strength of that partnership that we have seen is not just that we are bringing innovation to El Camino, but we are bringing the hospital into the innovation process. And I think today you're going to see some of the results of that process. When you think of medical technology that you guys get to experience, you may think one of these courageous folks in their lab or an entrepreneur in their garage just coming up with an idea, and that idea then translating into what you see in practice. The reality is that's not true. That process, well, it's a true step, but what you're missing is about 15 to 20 years from that idea to be translated into use with a patient. It's about $100 million to get from that idea to the patient, and it's a very torturous path. About 20 years ago, Dr. Tom Fogarty, who some of you may recognize, and some of you may have been to his winery up the road, he's probably one of the most prolific inventors in American history for medical technology. He realized that gap was a problem of helping these young companies, these young physicians, navigate that entire journey. That is what we exist for. So I have a very strong, remarkable team, very fortunate, who've experienced folks. Average experience is about 32 years in the industry. And what our goal is to help these guys get their idea to patients as quickly as possible. I don't know what else you want to.
That's great. Anyone want to add to that? So, Dr. Carroll, as a robotically trained cardiothoracic surgeon, when you think about innovation and advances in care, specifically in lung cancer and thoracoscopic surgery, video-assisted surgery, robotic surgery, what are some of the leading-edge diagnostic and treatment options that you have brought to El Camino Health to make it more accessible for our patients?
Well, thank you, Jasmine. First of all, that's exactly why it's so exciting to be here, to be a part of El Camino. Because of the innovation and because of the commitment to patients and to delivering the best care. And when you have a cancer patient, you really get to look them in the eye and know you're absolutely doing the best thing for them. Robotics, just first of all, doesn't mean that there's some autonomous robot that's making decisions and using AI to do whatever it wants. It's a tool, it's an implement that makes us better at what we do. And that's really fantastic because the impact on the patients is tremendous. You know, in the old standard of care, which is still being practiced around the country in a lot of places, people might have lung cancer surgery and sit in the hospital for a week, and they have to go through physical rehabilitation, and they have so many resources that they need just to get them through that journey. By doing it in a minimally invasive way, using this robotic technology, we have more accuracy, better safety, better efficiency, and smaller incisions. So people go home the next morning, they're taking Tylenol, and they're like, wow, okay, yeah, I can do this. And I'll tell people a lot of times, you don't have to believe me until we've done it, right? A lot of times people say, it's terrifying. They don't want to have surgery. They don't even want to discuss it or think about it. You don't have to believe me. I'll talk you through it. And then once we're on the other side of it, you're going to see how well you do. There's so much that we're making advances on. We're making strides all the time. And we're in a really unique position here in the Silicon Valley. The Fogarty Institute is phenomenal. The impact, not just on our practice, but on medical care. And look at where we are. I mean, this robotic equipment that's used around the world, those engineers are coming in the operating room with me because we're talking over different technical aspects, right? We're always trying to refine and work through these processes. There's a lot of companies in the area who have reached out. You know, I've reached out to them. We come up with different ideas. It's really an exciting place to be because we get to see the direct impact of all of this effort, all of this work in our patients. And our patients do better. They live longer and they have a better quality of life. And that's just really exciting.
Thank you for sharing. Thank you for bringing cutting-edge care to El Camino Health and partnering with the Fogarty Institute. Question for Dr. Jayachandran. When most people think about leading-edge care in healthcare, clinical trials come to mind, including research and experimentation of new medications and treatment protocols. We heard a perfect story with Evan. You're leading this effort at El Camino Health as the Director of Cancer Research and Research for the Enterprise, and it's happening here and now. Can you tell us how the breast cancer program is experimenting and adopting innovative approaches to care?
Love to. And I'll piggyback off of some of the comments that have already been made here. So it's my opinion that oncology cancer care is developing and changing at a far more rapid pace than any other specialty within medicine. And that is a wonderful, wonderful thing, obviously. But it means that we have to work incredibly hard to stay at the cutting edge of those treatments. We need to make sure that patients here at El Camino have first access when things are out and available. And we also have an obligation and a duty to contribute to the knowledge base, to participate in that research, to help develop new medications that can save thousands of lives down the road. And we are super thankful to be here with the Fogarty Institute. One of the trials that we are looking forward to opening up is an oral cooling device. It's called CoolGuard. Basically, it's like a retainer that patients wear while they're getting their chemotherapy. It cools the mouth to a very specific temperature and is intended to prevent mucositis, so the sores and ulcers that people can form as a result of chemotherapy. And so that's just one example of a study that we're looking forward to offering to our patients here at our cancer center. We have a number of clinical trials that we are currently running. Some of these are biobanking or biorepository studies. What that is basically building off of this concept of big data. So you can think of, in the past, if there's a rare cancer type, at one specific hospital, you might have 2-3 patients given that diagnosis over several years. And it would take forever to develop meaningful conclusions, even if you are researching and investigating. So what we do with biobanks and biorepositories is basically we are collecting blood samples or tumor specimens from patients at our institution. We are shipping that out to the central location. And there are hospitals all over the country, all over the world doing the exact same thing. And at this biobank, they're able to process those blood specimens, run genomic testing and profiling of the tumor, and connect it to the clinical data that we provide. And so you can imagine that in the course of weeks, various universities, institutions can access that data and draw very meaningful conclusions that otherwise would have taken decades to figure out. So that's something that we are happy to be participating in here. We also have a number of phase 2, phase 3 clinical trials investigating new medications. I'll just give you one specific example in the breast cancer arena. There is a relatively new class of medications called antibody-drug conjugates. So in the past, we've had traditional chemotherapy that essentially is poisoning some aspect of the cell cycle. And as a result, it has many side effects. And there's many people in the room here who can attest to the many side effects of chemotherapy and the problems that it can cause. More recently, we've had immunotherapy, which utilizes the body's natural immune system and T cells to target and fight off the cancer. And that's been a major advance in cancer treatment. We now also have a category of medications called antibody-drug conjugates. These are kind of 2-for-1 medications. They involve an antibody that is specifically targeted to an antigen, which is a protein on the surface of the cancer cell. And it's chemically linked to a cancer drug. So when we infuse it, although it's going through the entire bloodstream, it is latching onto and targeting the cancer cells specifically. And we can therefore use a much more powerful cancer drug linked to it that's very targeted to the cancer cells and causes much fewer side effects. So we're in the process of investigating one of these novel antibody-drug conjugates in the treatment of breast cancer. And, kind of building off of many of the stories that have been shared here today, we really want to make sure people here at El Camino, this is our community, this is our home, our patients are our family. We want to make sure they have first dibs when there's something new and great available out there. And some of you may have heard, there's been a lot of press on it lately. There's a new pancreatic cancer drug that's in the late stages of investigation. The data is just coming out. It was presented at the ASCO conference. When we heard about this, we collaborated. We pulled together an emergency IRB meeting, and I'm very proud to say that we now have access to that medication. We are in daily communication with Revolution Medicine, and we already have a series of patients lined up who are waiting to get this drug. So that's before many of the major academic institutions in the country. And so this is something that we really prioritize here at El Camino.
Sorry. There we go. 2 thoughts to that. That was, really, really exciting. Number one is if there are not that many hospitals that participate in the type of research that you were talking about. Right? If you don't participate in that research, you don't get the opportunity to see the new technology, the new therapies. So that is what El Camino offers you guys, right? Because they're doing that, they're getting the access back. The other one is you never know where that information is going to go. And what I mean by that is that someone is going to read one of the papers, one of the presentations, and say, you know what, I've just read something else, and put 2 things together and say, boom, and here's a new therapy. So it is that unintended consequence of participating in a study, sharing that data with the world, and some bright spark somewhere put something together. And so again, I just want to support El Camino. It's remarkable.
Yeah.
And absolutely, I 100% agree. That's how it goes with research. Not everything is going to be a slam dunk. Not everything is going to be a miracle. But we really just have to do our best. We work together very closely here at El Camino. I'm so thankful for the medical team and the colleagues that I have. I can share just an example. One of my patients, she is receiving treatment with an antibody drug conjugate. She had come in, young lady, very active, very advanced and aggressive triple negative breast cancer. So she came in and she was in tears. Her one breast was twice the size of the other. It was red, inflamed, incredibly painful. We did the scans. Unfortunately, there was cancer in the lungs and in some of the bones. We started chemo and immunotherapy, and I was praying beyond praying that it would work. And then unfortunately, one day she starts telling me that her leg feels weak and that she's incontinent. So we found out that she had cord compression. So that means that the cancer is pinching on the spinal cord, on the nerves, and causing weakness. So first thing I did was reach out to my friends in radiation oncology. We emergently got her into the hospital, started her on an intensive course of radiation. Thereafter, we were able to do some genomic profiling of her cancer cells, of her tumor, and her biopsy. So this is where personalized medicine comes into play. It's no longer one size fits all, that you get a diagnosis and this is the one treatment option you have. We're now better able to analyze a specific tumor and find targeted therapies. With her particular tumor, we found that there was a low level of HER2 expression, which is a protein that's sometimes overexpressed in breast cancer. And it was a very low level, but we decided to take the chance, and there's a drug that is specifically targeting that. It's called Enhertu. So we started her on it. We now are able to use what we call circulating tumor DNA testing. It's basically a blood test that checks the volume or amount of cancer cells floating around in the bloodstream. So initially we did this test and it was very high. They basically take 1 ml of blood and they say, how many tumor molecules do we see floating around in this? They found about 50. That's pretty high. We gave her the drug for a month, 2 months. Her pain started improving. We checked that circulating tumor DNA again. It was down to 1.6. And I'm really excited to say we just did the test again, and now it's 0. It's undetectable. And I was thrilled with this result. I invited her to come to this event today. She's a wonderful person, and she actually works at one of the local universities here. And so I was, excited. I was like, great, you can come, you can experience this wonderful event with us. And she said, girl, and she calls me girl. Sometimes she calls me baby girl. She said, girl, I'd love to come support your event, but it is graduation weekend. And I have about 3,000 entitled graduates that I need to make sure they get their diplomas and their regalia. And, it's just, I think the highest level of success, right? To Dr. Single's point that we want it to be that, yes, cancer is part of your life, but she was, just so nicely telling me that cancer was really her last priority and she had, bigger things and better things to do this weekend. And I think that's just a marker of how far we've come.
Yeah. Thank you for highlighting the multidisciplinary care that we have. We have doctors who are will hold the questions for the end, and we actually circulated some note cards if we can get the questions collected. So the multidisciplinary care, it really does bring medical oncologists, radiation oncologists, surgical oncologists all under one roof, where they're talking about new diagnoses, what the treatment protocols are. So thank you for sharing that story. It's testament to what we do here through that collaboration. Dr. Shumway, I have a question for you. As innovators in modern medicine, physicians are continually staying up to date on latest advances, as we all heard, in cutting edge care, and bringing it to the forefront for patients to easily access them. What are some of the most significant technical innovations happening in radiation oncology today?
Fantastic. I mean, I could talk for a long time about this. Let me just say, though, it's a privilege to share the stage with you guys, people who are bringing, these things to light. And Andrea, what you're doing at the Fogarty Institute is incredible, bringing new stuff to light that we use and that we depend on. And one comment I'll just make really quick, and I'll answer your question. Things take a long time to develop in the medical world. It's not an easy thing to develop new medical technologies, new drugs. And even beyond that, once something's developed, adoption takes a long time. And so I feel incredibly lucky to be at a place like El Camino where we are involved in the development and we adopt very quickly. In the radiation world, some of the biggest companies that make our machines are literally just miles up the road. And our department actually serves as kind of a showcase for other departments where we have the latest and the greatest, and people come and see what we're using. And, it's an incredible place to be here. Specifically, some of the things that we're doing in radiation therapy that we weren't doing very long ago. One of the things I wanted to highlight is what we call adaptive radiation therapy. We rely on artificial intelligence and technology in adaptive radiation therapy, where we are able to use artificial intelligence to see how the tumor is evolving and how tissues are changing on a day-to-day basis as we're going through radiation. This allows me to use smaller margins when I'm treat a more specific area, and reduce as much as possible dose to places I don't want to treat. That is an underrated thing. At the end of the day, cancer is cancer. We have to use a certain amount of radiation dose to kill it. But if we're able to reduce the dose to other tissues around, then your experience as a patient is a lot better and a lot improved. And so I find a lot of value in adaptive radiation therapy. Our department's adopted that, and we are seeing that improve almost, on a yearly basis or quicker as the technology underlying it improves. We're also using a new system called Identify, and what this does is it tracks your body contours and helps us to set you up for radiation. In the past, we used to use tattoos and markers and things like that were a little bit of a hassle. They took more time. They left marks on the skin and things like that, and we don't have to use those anymore. We have technology that allows us to get away from that, allows us to be more precise, more accurate, and just give you a better experience overall. One other thing I'll highlight really quick is, on the clinical trials aspect, we're constantly running clinical trials in radiation therapy and asking, what is the right dose? What is the right way to deliver this dose? And there's been a large shift over the years. I think everyone's probably noticed it here, where we're treating with fewer and fewer treatments, just trying to improve the patient experience. You might, I have patients who come in all the time with breast cancer, prostate cancer, and their father or mother or grandparents got radiation treatment decades ago, and they were expecting me to say, oh, you need 6 to 8 weeks of radiation, but instead I'm saying, oh, you need 5 treatments or something like that. And it's just incredible that we're able to do that now. It improves the patient experience. It actually improves my ability to target and kind of give more of a punch to the tumor. And, we're not compromising in any way our ability to treat the cancer. So I'm really grateful for these innovations and grateful to be at a place where we can adopt these quickly and bring these on board quickly.
Dr. Carroll, I know you're bringing to El Camino Health, minimally invasive approaches to care. I know you're a cardiothoracic surgeon, so I know you're also very well trained in the cardiac side of things. You've done amazing things that we have never done before from a minimally invasive approach standpoint. Can you speak to when we think about whole person care, right? We're taking care of cancer patients who have comorbidities, other diagnoses, whether it affects the heart or the lungs or the bones. Can you speak to some of the innovation that you've brought forth and some of the considerations that you're talking to the team about to build as net new programs to make it more accessible for our patients?
Yeah, absolutely. Again, every patient, I always try and encourage the mentality that they're the chairman of the board. They're sitting at the head of the table, and we're consultants. So we're going to pull up a chair to the table, and we want to fill that table. It's not just me, right? It's my radiation oncology colleagues. It's my medical oncology colleagues. It's our diagnostic radiologists. It's our pulmonologists. It's et cetera. There's this huge list of care providers, but equal footing at that table are the family members, right? I mean, I think your story was beautiful and very impactful because that's what this is about. It's not, no person exists in a vacuum. So when they're the patient, they're at the head of the table, we're all pulling up a chair to the table, and we're going to communicate, we're going to come up with a plan, and they're going to call the shots. But the more information that we can provide for them, the better we're going to do at it. So just to kind of give an example of how we can make big changes, if you look historically at the standard of care for somebody with lung cancer, how does that happen? Well, it's not always people that smoke, but historically, people that smoke don't want to think about it, right? Eventually, they get a CT scan, and we find something. Okay, we find a tumor. They get sent for a biopsy. They get a biopsy result. Then they get sent to an oncologist. Then the oncologist discusses it with them. Then they get sent to a surgeon. Then they get some imaging done. And you look at the national timeline, that can be 2 months before they get treatment. And imagine how much worrying and stress that causes in 2 months. So what the new paradigm and kind of what we're bringing to the table is, okay, patient has a suspicious nodule. Well, let's get some tests done right away, some imaging that week. Then we'll bring them into the clinic and we'll talk about it. And then we'll get a biopsy done. At the time of the biopsy, which by the way is not a conventional biopsy approach, which is fraught with some issues. It's robotic navigational bronchoscopy with biopsy. It's got to have a long name in order to be good, right? It's so much more accurate. It's so much more precise. And at the same time, the pathologists are right there. So we don't send them home not knowing what it is. The pathologist can tell us, is this cancer? Well, we take it one step further. Okay, we found a cancer. We're going to treat it. So while they're asleep from that anesthesia, that's why we call it a single anesthetic event, we do surgery. So we do an anatomic resection, either segmentectomy, lobectomy, complete exhaustive nodal dissection. We freeze the nerves in the chest walls. They don't have pain. So when they wake up, they'll wake up in the operating room, we'll come to the recovery room, and then there's 2 questions that we're going to answer. One, was it cancer? Yes. Okay, what do? We did it. So then the next day, they're going home. You know, I'm seeing them at 6 a.m. I take out their drain and, oh, okay, well, really? What's next? Well, just continue healing, right? We want to get you back to your life. So it's really exciting to be able to do these things and to have such a fantastic team that, you know, when you come together with ideas for a specific patient or something more global for a new technology, I was, you know, shout out to Dr. Jayachandran because just yesterday, right, I was all in a fervor about a new technology as something that I want to push forward with a research study. And pulled together a team, and she got me, she gave me the floor, and we're moving forward with that. So that's, I guess kind of a meandering answer, but hope that answers the question.
It does. Thank you. Yep. Question for the panel. Anyone can take this one. Prevention and earlier cancer detection is really the key to curing cancer. What are the new options for cancer prevention, screening, diagnosis, and treatment they're excited about in each of your respective areas of expertise?
I guess I'll take the floor here. When it comes to breast cancer, there's a lot on the horizon, and I would completely agree, right? We are talking a lot about all the research, all the exciting innovations, which is all super important. But obviously, if we can prevent the cancer in the first place, then everything else becomes a moot point. And we are yet at the point, despite all these amazing advances, to have a true cure for cancer. We don't have a magic bullet yet. We all hope and pray that we will one day reach that point. But right now, we have a number of different ways that we can attack a cancer. We use different modalities. We work together as a team, but we don't yet have that final perfect solution. We do know that there's a lot of things that are in our control to try to prevent cancer. Things like trying to lead a healthy lifestyle, participating in regular exercise, healthy diet. These are things that we can do. But obviously, so many cancers are not in our control. Many people in this room have done everything right by the books from day one and are still ending up with a cancer diagnosis, which is certainly no fault of their own. And we really need to be better about catching things early. I'm a breast medical oncologist. I'm very passionate about mammograms and screening programs. We are proud that we have a free mammogram program here for uninsured and underinsured women. And we're doing hundreds of free mammograms every year, thousands of them since the inception of this program. And we are able to find cancers earlier when we do that. Some early stage breast cancers, they have a 99% plus cure rate in terms of getting surgery, sometimes chemo, but sometimes not. Endocrine therapy, radiation, we're able to use these different modalities and achieve very high success rates. But it is obviously very important that we detect it early. We do have a number of newer tests that are available, but mammograms remain our gold standard. That's what we recommend to everyone. I mentioned that blood test when I was talking about one of my patients earlier. So we do have blood tests that can identify circulating cancer cells in the blood. We now have something that we call liquid biopsy. We can use that for generally more advanced cancers, but we can often get a lot of the same information that used to require an invasive procedure. So we no longer have to put someone under sedation, put a needle into an organ and pull out cancer cells. We can actually do a simple blood test, identify the cancer cells that are present there, and run very specific genomic testing, look at the gene expression, the expression of different markers, and find targeted therapies. So there's a lot of advances in terms of early diagnosis. There are a lot of advances in terms of targeted therapy, but when it comes to the day-to-day, the average woman, it's still super important that everyone goes out and gets their mammogram.
Yeah, and I just want to reinforce some of those. I think that what we've learned over the last few decades is early detection, right? Just as you were saying. If we can detect early, we do have a lot of tools that are very effective at eliminating the cancer or reducing the cancer. So what we're seeing is a lot more effort going into that, making some of these tests non-invasive, so blood-based, targeting needle biopsies a little better. We've got one company actually at Fogarty right now that's looking at skin cancer detection digitally. So no need to take a biopsy. So a lot of work in that activity, but really holy grail is find cancer as soon as it comes out.
Can add a thought to that too, because obviously that's what we want. We want to get it right at the beginning, get it very early, treat it, put it behind us. But I guess a technology or newer development that I want to just share, and that's something called pulse electric field ablation. It's a energy delivery system that's actually the same way that McDonald's makes their French fries so crispy. It's true. Fun fact. But it's a form of high intensity energy that doesn't transfer any heat. So we can ablate a tumor, we can zap it, but it doesn't denature the cells. So the cells are still there, but they're dead. But because their structure is still intact, the body can investigate them. So it stimulates the immune response to target those cells. Well, those cells are unique because they're cancer cells. They're different than the other cells in the body. So for patients who have advanced disease, they have metastatic cancer, they have multiple tumors, who have failed our traditional treatment strategies, we're finding that by ablating one tumor allows the body to identify cancer cells elsewhere. And sometimes we're seeing a complete response that we're activating the body to attack the cancer, because the greatest tool we have is the body itself. And in other cases, we're just seeing a regression in the cancer. So people are living longer. So at any phase along the disease process, we're always pushing to make it better. And this is a really exciting one.
So I gotta say, I've worked for 20 years with pulsed electric fields and never heard it described that way. So I think so I'm going to steal that from you, because I think that's pretty cool that now what we're doing is using the technique that's causing the cancer, which is the McDonald's fries, into a way of solving the cancer. Love it.
Mm-hmm.
Clearly not sponsored by McDonald's.
How do I follow that? Dr. Shumway, at El Camino Health, we take a lot of pride in delivering integrative oncology care. So what that means is we're taking care of the patient for their cancer diagnosis. But, again, as we pointed out earlier, patients have other conditions. For our patients, we have mental health support services. We have cancer health coaching, as everyone saw in the video earlier. We offer a lot of other services to really meet where the patient is. Some of these patients are the patients that come to us in collaboration with primary care partners, orthopedic surgeons. You recently have been working with those specialists in managing care that using the technology that we use for cancer care, but using it for a different purpose. Can you speak to that a little bit? I know I'm being vague.
No,
I'll let you
absolutely.
answer it.
Yeah. I'll talk about that here for a minute. I'll just say, though, on that vein, sometimes we pigeonhole ourselves in the cancer world and we treat a cancer and forget that we're actually treating a patient, right? And it's easy to kind of hone in on just the cancer and forget about all the other things that might be going on. Yeah. One thing I really like about El Camino is there's a lot of support for trying to just take a step back, and acknowledge everything else that might be going on. And in the radiation department, I don't give chemotherapy, but I have a lot of patients who get chemotherapy. And so I depend heavily on nutritionists and speech therapists and physical therapists to help with every type of side effect or issue that the patients may have as they're going through their cancer care, a lot of which aren't related to radiation, and that's okay. What you're alluding to has become a very important part of my practice. A lot of my patients, as they're going through radiation, I'll just ask them, hey, what's going on? What's your kind of chief issue today, chief complaint? And often it's not related to radiation, not even related to cancer. It's related to my knees bugging me. I have an arthritic knee, or I have plantar fasciitis, or my Achilles tendon's really bugging me. I used to play pickleball. I can't play pickleball anymore. And there's a use for radiation that was actually developed in Europe, and they've been doing there for a couple of decades now, called low-dose radiation therapy. And simply put, it's a very low dose, not a cell-killing dose or a tumor-killing dose, but a dose of radiation that brings down inflammation. And it's passed many clinical trials and shown a lot of improvement, for patients with osteoarthritis, plantar fasciitis, somewhere around 80% of patients will have a response in pain with this type of radiation therapy. And I offer this radiation therapy now, and kudos to El Camino, they bought me a machine for this. A specific machine for doing this type of radiation therapy. Some of my patients are my cancer patients. Some of my patients are just people in the community who have this afflicting them and want to come for this. And so why is it important to have a specific machine? Well, you can probably do the math. If I have one slot for a patient on any given day, and I have somebody who has an issue with their knee, and then I have somebody with the cancer patient is going to get it every day. And so I love having my own machine, so I don't have to worry about that. This machine is actually delivers the type of radiation I'm doing with low-dose radiation even better than my big cancer killing machines do, right? And so, it's an incredible thing that, El Camino has been able to get this for me and for our department, and that we're using this now.
I have a final round of questions for each of you. If you have the superpower to change one thing in cancer care to affect outcomes and change for decades to come, what would that be?
Start up that end.
Good call.
I mean, I don't know if this is cheating to give this answer, but honestly, I think it would be awareness. If we could get people into the medical system, we can treat them. We can take care of them. So many people pull the ostrich maneuver, right? Bury their head in the sand. They don't want to know. They don't want to know until it becomes a real problem. But if we can engage with people before it becomes a problem, there's so much that we can do.
Maybe I interpreted this question wrong, but I took it very literally when you said superpower. So the first thing that came into my mind was time travel. If I could time travel, I could fast forward and have access to all these new treatments that are coming out. I can't say how many times that there'll be some new advance, some new drug that's approved, some new technology that comes out. And I think back, unfortunately, to people that we have lost. And I think, gosh, that would have been amazing if Mrs. So-and-so had access to that drug. And on the one hand, that's heartbreaking. But on the other hand, it's an inspiration. And I really wish that we could just kind of fast forward to the future because as oncologists, we're all very impatient people. I think that's, again, one of the good things about working here. Dr. Carroll was telling me about this pulse electric fields earlier this week on the phone. And I didn't fully understand the technology, but he was really passionate about it. And so, we brought it to our research team and, he was asking, how long does this take to get through? And, they were like, well, a few months, we have to go through some research committees. We have to go through the IRB. And he's like, well, that's okay. No. I want this to be open in 1 month. So I will go around and I will talk to everyone in administration and I'm going to figure out a way to make it happen. And I just love that, right? We don't want to wait. We want access to the newest and the best for our patients. They are our inspiration. I am humbled on a daily basis because as far as we've come in cancer care, we just have so far to go. And as much as we may be experts in our field, I learn something new from my patients every single day. Someone will come in with a new situation I've never encountered, a slightly different diagnosis, a different combination of comorbidities, things that we have to figure out and address. And I'm endlessly inspired by just how much strength of spirit people have, how much physical strength, emotional strength to fight their cancers and get through treatment. And it's just an honor and something that I'm thankful for every day.
I'll be quick here. One of the worst parts of treating cancer are side effects, chemotherapy, radiation, et cetera, et cetera. We've seen that getting a lot better. My superpower, if I could pick it, would be a pill or a type of radiation or something where I can treat your cancer with 0 side effects.
So I'm probably a little more practical. We're not going to eliminate cancer within... No, I didn't mean that. Yeah, that did sound like a dig at you. It wasn't. the original question. I don't think we're going to eliminate cancer in the next 10 years. And so the superpower I'd want is to help reduce the anxiety that patients exhibit. You said before, one of the most powerful tools that we have to treat cancer is our own will. And I think that anxiety robs you of that strength. So making it a little easier for not only the person undergoing the cancer treatment, but also their family.
Well, that brings us to a wrap. I want to thank all the panelists for their thoughts and input today. If you take one thing away from today's panel, I hope it's that innovation in healthcare and cancer care is alive and is happening right here and right now. And it's happening on our campuses every single day. The ideas and examples we've shared with you today are the ones that we're in the process of implementing or have just implemented. This work is important to me personally because I lost my mom to multiple myeloma about 15 years ago. So that time travel, multiple myeloma care is much more advanced now. So being part of the team here, revolutionizing cancer care, is a calling for so many of us and probably for so many of you who've joined us today. We're not only committed to providing the very best end-to-end frictionless care for our patients, but also being on the forefront of what's possible. It's why I'm proud to work here and to do what I do. Thank you.
Concern is very proud to partner with Cancer Care and support the cancer patient's emotional health journey through this difficult time in their life. Cancer care patients are getting treatment for their body, but it's so important they're also taking care of their emotional well-being. It is natural that they're feeling anxious, frustrated, concerned, anger. This is an incredibly stressful journey, and not only the patient's lives, but the lives of the caregivers. And what Concern is offering are individual counseling sessions and group sessions, and it's for the caregivers too. During this challenging time, having a confidant, somebody to speak to help us feel hope. And for the caregiver too. Caregivers often are carrying a heavy load. They feel burnout. They have stress, anger, anxieties. And again, it's so important that we're caring for emotional well-being just as we are our physical well-being during this difficult time. One important note about this benefit is it's completely free to cancer care patients. Another important note is we have several counselors that we've recruited that are bilingual in many different languages. So it's important not only that you're connecting to a counselor who understands what you're going through, but they culturally understand you and can speak your language. Accessing the program is easy. You can call or email our dedicated team member who coordinates the individual counseling sessions and can help an individual, whether that's the patient or the caregiver, get connected to the group sessions. These are good listeners. A counselor is someone who is going to help you cope through this difficult time, and it's perfectly okay to get help and just know that you're not going at this alone. You have help and support through this journey.
Okay. I'm Dr. Shamli Singhal. I'm a surgical oncologist here at El Camino. Been here since 2005. And I want to welcome our panelists. And so I'm going to start at the far end. Dr. Lee is radiologist. Dr. Taylor is a psychiatrist. Dr. Lai is a urologist. Dr. Rajasekar is medical oncology. Dr. Liu is breast oncology. And Dr. Jillian Shea is a GYN oncologist. So we welcome them all. And so just for your fun facts, I have collected these facts known to some people, unknown to others of them. So which one of you is a twin? I am a twin. You are a twin. Okay. And so which one of you could not make up their mind about which ice cream they wanted to eat, so they got 6 flavors and chose later? And then which one of you got through medical school eating peanut butter sandwiches, ice cream, and white bread? And then which one of you managed to get a lifestyle medicine certification in addition to all the other training? Oh, secret. All right. And then which one of you likes a certain animal and actually travels, a capybara, and traveled to Japan to visit them, even though they're from South America? And the last of which is, which one of us likes to cook and likes to make fusion food? So we're to your house later.
Thank you.
Well, that's the risk I take, I guess. And for the fun fact about me is, which one of us played varsity basketball in college? That was me. Okay. Okay, so we'll get started with our panel. And remember, we have one of the things that's really important and hopefully has come through in our day today is that we believe that all of us have an opinion on how we deliver care, right? And the patient's at the center, and we argue, we discuss, we try to promote various things. But the people that are sort of behind the scenes of all of this are some of the specialists that you don't visit in clinic. Right? Some of the specialists that we don't visit in clinic who are critically important to our success are pathology, radiology, interventional radiology, etc. And so I'd like to ask Dr. Lee a question, which is, what is the difference between diagnostic radiology, interventional radiology, and any other kind of radiology?
Hey everyone, I'm a diagnostic radiologist, and generally, I'm in a dark room reading somewhere, like a variety of scans, like MRIs, PET, CT, etc. We do occasional procedures that are less invasive, like maybe more like fluoroscopic procedures. But whereas a interventional radiologist has the training to do more invasive procedures, like with catheters through our blood vessels, for whether it's for like strokes or for other oncology cases. So yeah, you wouldn't want to trust me to do any interventional radiology.
Excellent. All right. So I'm going to ask each of you guys, what do you tell your patients about exercise? What do you tell them about that?
I can volunteer.
Yeah, you can volunteer.
So when I see a patient in the clinic, one of the things I always talk about besides treatment of the cancer is what the patient can do from their standpoint to improve their outcomes. And two things that I always talk to patients about are nutrition and exercise. Study after study comes out saying that any kind of exercise, which includes not just cardiovascular activity, but strength training as well, has been shown to improve outcomes. And in one study, which was all the rage a few months ago, for patients with colon cancer, those who did 2 days of cardiovascular activity, which is running, jogging, whatnot, 30 minutes a day or 2 times a week, and people who did 30 minutes of strength training 2 to 3 times a week, the positive effect they got from it was similar to the effect you get from chemotherapy for colon cancer. We should be prescribing, exercise to people. Unfortunately, it might end with the prescription because you have to go back and follow up on it. But I think we are more and more understanding the importance of exercise and how it affects cell autophagy and how cells die when there's abnormalities in the DNA. And I think it's an underrated potential that we have for treatment of cancer. Again, it's a correlation, not a causation. You can't prove that the exercise is what helped the patient, but patients who seem to be more active in doing these things seem to have a better outcome.
Okay, so the way that I've heard it described, which I'll just add to this, is that you want to do everything you can do to make your body hostile to cancer cells, right? And so if it's food is medicine, great. If it's taking care of your mental health so that mind and body work in the same direction, that's great too. Managing your stress, that's another one. I'm taking a few of these from our lifestyle coach here, Dr. Lai, but all the things that you do to keep your heart healthy are the things that do to keep your cancer at bay. And so those are things that you can yourself engage in, right? And a couple of the patients have said, that's just adding more burden to my existence. Like I already have cancer, and here I am having to measure myself against sections. These are sort of aspirational goals. If you would like to incorporate any of these things, even in the smallest way possible, that's great. So I will only make one small comment about exercise, is that there's this thing, and it's a meme that's out there about exercise snacks. So exercise snacks are that you take 5 minutes. You don't have to go to the gym, you don't have to do anything, but just 5 minutes. And you can walk around the block, walk up the stairs, and those all count. So that's one thing. So Dr. Lai, what do you tell your prostate cancer patients in terms of going forward on
there's 6 pillars of lifestyle medicine. Then mentioned diet, exercise, sleep is also very important, right? Regular sleep, 7 to 8 hours. Socialization, right? Being able to have a community around you. That has been shown to be very helpful.
Yeah.
Socialization, right? So that's important. So sleep, diet, exercise, and then don't do drugs. That's all. Yeah.
Toxins.
So I think those are the things I tell my patients. So in terms of prostate cancer, a lot of it is, how do I keep myself healthy, right? Because and what I tell people is that still the most common cause of death in men with prostate cancer is still cardiovascular disease. So anything that you do to keep your heart healthy will make your life easier and prolong your life. Yeah.
Right. So, Dr. Liu, you are a breast surgical oncologist. So there's a lot of confusing data out there about when to do breast screening, right? And so what is your recommendation about it? And then how people should go about that?
Generally, the recommendation is to start screening mammograms when you turn age 40, and that you should be doing it annually at that time. For some special at-risk populations, we may recommend that they get screening mammograms 10 years before the youngest person in their family had cancer. And so that would be on an individual basis. We also think about your breast density when we talk about a mammogram, as we know that many women have dense breasts, and that can make cancer detection harder. And so if that's the case, we typically add on additional screening tools such as the ultrasound or MRI. So these are all very personalized discussions. And then a question I get quite often is, when should we stop screening mammograms? Right. And so right now, there are no guidelines to say when we should stop. And for my patients, I typically recommend that we stop when they no longer would pursue additional cancer treatment if cancer was found. And patients are living longer and longer these days. And so I encourage screening up until 80s or 90s.
Great. So I would like a question directed to Dr. Taylor. And I'll share something about Dr. Taylor that she doesn't mind to be shared, but she herself is a breast cancer survivor, and she's a psychiatrist by training. And there's a very big difficulty in being a patient in addition to being a doctor. So I'd like her to tell you the story of her radiation treatment and her escape that day from the last day of radiation treatment.
Yes. Thank you, Shanley. I think the cancer diagnosis certainly gave me a new perspective on what my patients were going through. And when I had radiation, I'd had a lumpectomy and gone right into radiation. But I didn't want to be sick. I didn't want to be told I was sick. I didn't want to have any reminders of this. And so I think it was the last day of radiation, my bags were packed and off we went on vacation, pretty much to the airport. I had every kind of skin coverage as well, but I think for me, the idea was I needed to have something. For me, it's always, I know when I come back from a vacation, when my next vacation is. I came back last night for this, and I'm already trying to figure out when I can. But for me, I think it's always been helpful to be able to judge when I need to what I need to look forward to. I think that's one of the things that I found was helpful, is looking and being patient enough to be okay with where you are, because that's really hard for doctors. And I think it's really hard for a lot of people to just be able to sit And I recognize now I'm going to try to make my next version of that a little bit better. Maybe I don't have to run out the door quite right away.
She also told us this funny story. So, mind you, she just had surgery. She just had a lymph node removed. She just had radiation. And so then determined to be as normal as possible, determined to go on this vacation to Hawaii, and then tried to put her bag on the overhead bin.
Can't do it. Right. And realizing you have to ask for help. Suddenly realizing, what am I gonna, how do I carry my suitcase? How do I carry my backpack? How do I got the things for my arm. I worried about the lymphedema, but I didn't think about those kind of things, like, what do you do with the suitcase?
Right. So I have a question for Dr. Shea. So Dr. Shea is a GYN oncologist. So she deals with ovarian cancer and uterine cancer and vulvar cancer and all of these other complicated things. Your patients want to travel, right? Do you tell them anything special about travel?
I think it's pretty personalized. It depends on where they are in their therapy, because when people are first diagnosed, where our intent is to cure, and so we don't want therapeutic interruptions, and it's important to get through your treatment in a certain time frame. So usually, if they're in first line therapy and the intent is curative, I'll tell them, you have to reschedule. I'm happy to write you a letter. And most airlines are sympathetic to that, and they do let people reschedule. But then, sometimes, unfortunately, cancer does come back. And we see that a lot, unfortunately, with ovarian cancer. And at that point, our goal changes, because recurrent ovarian cancer is generally not curable, and it's palliative. And so even though people are on treatment, this is it. This is their life. They have to live this life. And so we'll try to squeeze trips between chemo sessions, or give them a little bit of a break when they're trying to go on a trip. I want my patients to be open with me about their goals, so that I can make their treatment align with their goals, because this is their one chance.
Yeah. So I have a few pro tips about travel when you have cancer. One of which is to take your list of medications. Maybe you take an extra week of your medications with you, so that you're not in Zimbabwe trying to find your medication because you left it at home. So that's one big one, because not every country has the same medicines. Medicines are hard to get that. And then you may or may not know this, but you can sign up with the TSA to go and they'll pre-register you so that you can go straight through, so that all your medications that you're taking, you can go easily through the TSA, because you have a little pass that says, I'm a cancer patient, I checked out, and makes life a little bit easier. Things like wheelchairs, things like your oxygen, things like, I had this recent conversation with a patient about their oxygen, and they said, I'm going to take a trip that takes 9 hours to fly there. And I said, that's cool, but your oxygen tank only holds 2 hours of oxygen. So did you plan on a different strategy? But people don't necessarily think about all these accoutrements. And so we have lots of insight. There's a thing called Fit to Fly. There's a bunch of other stuff that you can do to help you. I mean, we want you to travel. We want you to go to the place of your dreams. We want you to do all of these things, but we want you to do it safely, so that we don't get the phone calls that I get. So I was biking on the south of Spain, and I got a bowel obstruction. And so now I'm admitted to a hospital somewhere in the south of Spain. Can you please send my records? So, we want you to be safe. So we have a list of things in the cancer center and other places to help you do these things. Because obviously we don't want to get that phone call, and we don't want you to have that phone call either. Right? And Catherine,
And I would say that sometimes the recognizing the anxiety that comes up about these things can sometimes put on blinders. And so, as you're saying, having that list, recognizing, what do I need to have that's planned out ahead of time? Because I think that's really important to address, so that you do. I also get lots of calls. There's certain medications you can't prescribe in Hawaii unless you have a Hawaiian state medical license. So there are a lot of states that won't even allow you to do that. But if you look and plan ahead, the anxiety comes down and you can look at what you need and make sure you really have it and do it safely.
Right. So Dr. Lee is at the forefront of diagnostic radiology, right? And diagnostic radiology has changed quite a bit for us. So things like the PSMA scan, things like using higher contrast agents to find cancers earlier, to detect recurrence earlier, to do any of that. Can you tell us a little bit about the value those kinds of scans add to our practice? So PSMA, dotate, all of that.
Of course. As you know, like technology is evolving rapidly these days, including all of medicine, including radiology. Specifically, like in the world of nuclear medicine, we used to use something called FDG PET for a lot of oncology staging. But in recent years, there are all these new tracers being used, like such as dotatate, PSMA, etc., that are taken up by cancer cells, in addition to other types of non-cancer cells, but it helps us be more specific with and more accurate, perhaps, with our reads in terms of helping diagnose and or stage what's going on in the bodies. So, and just all these new tracers coming out as we speak. So it takes. I think for us physicians, it requires us to keep up to date with new innovations, new technologies that could help improve patient care overall.
Yeah.
I think I just want to add on to what Dr. Lee had mentioned. Like the topic today is the multidisciplinary cancer team, and I have patients here today where typically we would have diagnosed them with prostate cancer, and Frank would attest to this, where we did not have these scans before, and these were patients who we would treat with traditional radiation or surgery, and 1 year down the road they'll have cancer pop up in a lymph node. Now, the advantages with these scans is that you can catch those lymph node metastases even before traditional imaging can catch it. And this is the kind of discussion that happens at a tumor conference where the radiologist will review this newer generation scan that we have. And initially, our plan might have been to do just surgery or radiation. But once we find out that there's a lymph node involved, that traditional scans did not find them, now we get more aggressive with how we treat patients. Whereas we might have just done surgery for these patients, now we add additional therapies because there's benefits and there's a higher chance of cure. So that's how these newer generation radio tracers help us identify cancers much earlier and treat them more aggressively, leading to better outcomes for patients.
Right. So I would like to talk to Dr. Shea a little bit about this because she uses the robot a lot, as does Dr. Lai. What's new on the horizon on the robot?
So now there's a new robot now. It's single port. So instead of using multiple kind of incisions to get to the area that you need, single port robotics now allow you to operate through a 3-centimeter incision. Whereas before you would require maybe 4 or 5 ports. Now just one incision, then you can achieve the outcomes that you want with less pain, shorter hospital stay, less bleeding. So I think that's one thing that's new.
Okay, Dr. Shea.
We have the newest Da Vinci DV5 platform, which has been really wonderful to use. A couple of things that are new in it from the previous generation. The camera resolution is incredible. And it has maybe 4 times the pixels. So you can see these tiny blood vessels that you couldn't see before. So it helps you avoid getting into bleeding. It helps you be more precise with surgery. It's easier to do multi-quadrant surgery. So previously you would just be, if you divide the belly into 4 quadrants, you would be in mostly 2 quadrants. Otherwise, you'd be limited by what you can see and how you would be able to move your robot. But it's easier to do 4-quadrant surgery now, which is really important in ovarian cancer because it, generally spreads through the entire belly. And now we're able to explore doing even ovarian cancer debulking surgeries, which were previously always done open with the robotic platform. And then one of the newest features that I've really appreciated is this thing called telepresence, where you can dial in a friend using their intuitive app into your OR session. They can almost like a FaceTime, except they can see your surgical field. So you can, if you have a tough situation and you need advice from maybe a different specialist, then you can dial them in. And that's been really helpful because that person can be there instantly as opposed to like holding in the OR for an hour while they drive in. So that's been helpful. I'm trying to think of other things, but those are pretty good.
Well, what percentage of your surgeries are robotic now?
Probably 90%.
90%. Excellent. Yay. So we've gone from big open surgery for debulking to laparoscopic semi-open to now robotic. So what that means for the patient is for the surgeon, it's a lot, it can be a little bit longer of a surgery, but for the patient, it's an easier, faster recovery and fewer lifelong consequences of big open surgery. Okay. So we'll take questions at the end. And so the thing is that you can see it in radiation oncology. You can see it in surgery for sure. What is the de-escalation plan, right? How do we then not do as much big open surgery, and how can we do it so that the damage and the safety to the patient is much better? So imagine you had big open surgery. You can develop a hernia from that. You can have pain from that. There's a lot of stuff that happens, and we are trying our level best to decrease that. So in breast surgery, what are you doing differently? And maybe you talk a little bit about oncoplastic surgery.
Yeah, of course. So I actually got a question out there at the table about this, but historically in the past, when you think about breast cancer and surgery to remove it, most people are thinking a mastectomy, meaning complete removal of the breast. However, these days, with all the imaging advances that we have and all the tools that help us find the tumor in the breast, we're actually able to do a lot more lumpectomies, meaning removal of just the tumor itself and leaving the rest of the breast alone. And then in the past, if you do that, there could be a divot in the breast, it leaves a scar on the breast. And so these days, we're actually really focusing on how do we recreate the breast, create a natural look so that patients are living their life after breast cancer without having to think about that scar and that deformity. And so that's called oncoplastic surgery. And so here at El Camino, we partner with plastic surgeons to create a nice breast contour after the surgery. We offer it on the side of the cancer as well as the side that doesn't have the cancer. So patients can get that done at the same time as their cancer surgery because we want the bra to fit afterwards, obviously.
Okay, so there's so we've talked about mastectomies for generations. Okay, but a lot of people want to go flat against the chest wall, right? And there's something the plastic surgeons do flat against the chest wall called a Goldilocks mastectomy, which is what?
So a Goldilocks mastectomy is a type of mastectomy where we are removing the entire breast tissue, but we're leaving a flap of skin underneath on the bottom, and that will fill in and give a little bit of a small mound on the breast. And so it's for patients that like to be flat but don't want to be completely flat. And so it is a little bit of in between.
So I learned from a few of my patients something that, I was so happy that we did this surgery, that I was happy that they were living their life and this and that, but they were very conscious of their scars, very conscious of how their breast and their image looked. And what do you think, and I'll ask Dr. Shea and Dr. Liu and Dr. Rajasekar and everybody to comment a little bit about what do you think the effect of image is on you're living your life, you're going out of the house, you're doing any of your activities?
You mean like the appearance?
The appearance, right? Because it affects your psyche for quite a bit. Yeah.
Yeah. So when we think about oncoplasty, we think about how do we place the scars and incisions so that if you're wearing a low-cut dress, like how do we not see them? And so typically we're using very classic plastic surgery incisions. The scars are hidden at the lower crease of the breast and around the areola. So those heal quite nicely. There is a lot of anxiety when patients look at themselves in the mirror and they see their scars from cancer and they don't want to be reminded of it. And so we try our best to help them live their life after cancer.
Right. So, Dr. Taylor, can you talk a little bit about fear and fear of recurrence?
Yes, definitely. I think that's something that you hopefully make it through the first stage, and then you get hit with the waiting. The team tells you you're done, you're through with cancer, and that's great, and it's fabulous. And we always wish to get to that stage, but then there's the waiting and the fear, and what happens when it comes back. And every 6 months you have your some follow-up or some other different type of follow-up. And I think it's really important to recognize how impactful that is. Just even going to the part of when you look in the mirror, someone else may not see anything, but you see a reminder of an experience. And it's not just we talk about PTSD that has specific criteria, but sometimes it's just the fear because you had that memory. This actually did happen to you. You were the one that was that statistic. And why won't you be that statistic again? And I think being able to acknowledge that that's a fear and it's real. And there are even things in psychiatric parlance that we talk about in terms of even things like death anxiety or worrying about dying eventually. But I think looking at that fear and trying to figure out what are some things that you can do to lessen that, to acknowledge it, to live through with it, and then to be able to put it aside so that it doesn't impact what you do. Because I think that's the part that's really hard, is sometimes to sit and feel that, but still do the other things and not have it impact what you're doing. And there are a lot of things, I actually, just even back to the exercise question. And I thought about it and I thought, I would say, don't let perfection be the enemy of the good. Yes, say you're anxious and move on and say, okay, what can I do that might help with that? Or what can I do to distract myself? Can I just walk to the mailbox, put your tennis shoes on, or get on the treadmill with no shoes? That was something what is it that you can do to incentivize yourself? Or is there if you don't know about the things that incentivize you, is there someone you can talk to who can help you figure out, oh, hey, I like to exercise as part of a group, or that's the only way I ever do it, or I just want to be able to do something. So sometimes having that ability to talk to somebody and figure out what is it that's going to help me get past this thing. This is impacting me. Or I look in the mirror and I see something. No one else sees it, but I see the reminder of what I went through. And I don't want to think about that in the morning. So I think there are a lot of things that can be done, whether it's getting into habits of just, this is what I do and I don't think about it, or acknowledging it, having your moment, doing the techniques that someone might teach you, and then moving on. So I think it's important, though, not to put it under the carpet. Sometimes I say is if you stick it under the bed, it's going to pop back out. So I like to say, put it in the chest that's right there in the middle of the floor, and open it and lock it and walk by it every day and recognize that it's locked in the chest and it's not going to escape out of that chest. But you don't acknowledge, you don't hide from it. You do something to acknowledge that it's there and then move on.
Yeah. I think cancer care is a team effort, right? It's not just the physicians, it's the family, it's the friends, it's a support group around you. So access that. Well, whatever works for you, that's what you should do.
All right, so I'm going to switch gears a little bit and ask Dr. Bajsaker what he thinks about these cancer tests that are popping up everywhere you go on vacation.
You're the 10th person today to ask me that question. So my general opinion on this is basically I think you're talking about multi-cancer early detection, or MCED tests that you might have read up or seen advertisements for, and the sister child of it, which is whole body MRIs that are done to screen for cancer. When we think of cancer screening, we think of population-based investment and what that particular population is going to get out of it. You might always hear individual stories of people who got this test and they got diagnosed with cancer, but studies have shown, and actually there was a study done out of Europe just in the last few months that had a readout recently about these multi-cancer early detection tests, and it did not find that people who got the tests versus people who got traditional screening, like what we recommend for breast cancer screening, PSA screening, colonoscopies, it did not make people live longer, at least in the current way the test is being done. I think the science is heading to to a level where the chances of false positives, where you get a test and you get a false positive, now you're getting a biopsy, and the biopsy is inconclusive. Now you're removing a part of the kidney, and then it comes back saying it's a benign tumor. This patient went through this trauma of getting all this, thinking they have cancer. Now they've lost a part of their organ, and they didn't have cancer. The science is still lagging behind. It is a process. I think it will get better. The false positive, false negative rates will get better. But I think at the current state as it is, if you look at the disclosures for these MCED tests, it's like a 50% negative rate. As in, you get a test, it shows positive, it might be wrong half the time. It says it's negative, it might be positive half the time. So you can rather flip a coin and save $1,000. And, but it's not a takeaway from the fact that these studies will inform the future. I think this is going to happen. I think there will be a time in the next 10, 20 years where you can do a test on an annual basis, and it will tell you, okay, this signature went up, and you might have radiological studies that are more advanced that can say, okay, there is a half a centimeters thing that's growing around here, and we might have technologies by robotics or whatnot that can cut it out. Or there might be a pill you take that you can actually, this is very fascinating, you can actually find what cytokine or cancer-causing mutation is causing the interleukins or chemicals within the body signal to go up, which is stimulating a certain organ to develop cancer. And there might be a pill that we could give before the cancer happens. I think this is going to happen. I just don't think it's ready for use right now. For an individual patient, I was just talking to someone who said, I'd rather pay the $1,000 and get the peace of mind. And I told him, well, you might not get peace of mind. You might just get more anxiety with this.
Exactly.
Yeah, so that's where I stand on this.
Okay, so what happens when said patient pays $1,000 and gets an MRD scan, or not MRD scan, a MCD scan, and then they go to radiology? And then what happens in radiology?
I totally agree with everything you just said. I feel like, just to reiterate, like with these whole body MRIs, although there are cases where they do detect something that's real, oftentimes there's all these incidental findings that are found, and then we go down chase down this rabbit hole of figuring out what it is. It gives the patient anxiety and costs a lot of money. And then when it gets to radiology, unfortunately, as you said, medicine's imperfect, including radiology. A lot of things are not clear-cut currently, and oftentimes we don't know the answer either. We might just say indeterminate, consider follow-up at some point. So overall, all this gave was just more anxiety to the patient, and it cost a lot of money too. And yeah, I don't know, like sometimes my colleagues and I just don't know the answer. We just say, well, all we can do is follow up.
I see. So then people are in an endless loop of indeterminate, right? And then it goes to Dr. Taylor as, how do you get rid of this anxiety? How do you get rid of this fear that something in my body is growing, right? And that becomes a big challenge. All right, so I'm going to ask Dr. Shea. So you have biomarkers, right?
Yeah, CA-125.
What do you counsel your patients when their CA-125 bounces around?
It does fluctuate. Most people, so CA-125 is an imperfect marker. In general, it's correlated with ovarian cancer and metastatic uterine cancer. A lot of times when there's a massive disease burden and a lot of metastatic disease, it can be very high. So the threshold is anything above 35 is considered abnormal. And then with metastatic ovarian cancer, sometimes we'll see it in the thousands. So in general, when people are on some kind of successful treatment and they have a high disease burden, like let's say they have a surgery to debulk the majority of the ovarian cancer, you'll see a huge drop. And then when they get their chemo, it should drop with every successive chemo. And if it doesn't, I also have anxiety because in general, it should be dropping. So if they have, a couple consecutive, it's not any individual number, it's the trend. So if they have a couple consecutive rises, and we would get a CT scan to see what's going on, we treat disease, we don't treat a number. Right. And then let's say in the typical case, because ovarian cancer is very susceptible to chemo, we'll see the CA-125 drop back to normal. And then after completion of chemo, we'll follow patients CA-125, depending on what treatment they're on, either monthly or quarterly. And it does fluctuate, but as long as the numbers are in the same range, that's okay. Again, it's more the trend rather than the actual number. And then any CA-125 uptrend has to be verified with a scan, because if we treated a CA-125 number with a negative scan, then, what if the CA-125 is just fluctuating and you give them treatment, they get all the toxicity of treatment, but, there's nothing going on in the body. So
Right.
it
So
doesn't
that's
make
a
sense.
la land that's very anxiety provoking for everyone. So I think for many of these other cancers, like we are doing Signatera testing, we are doing circulating tumor cells of all these different things. So every specialty has this challenge of what to do when the number goes up, right? It has to have something else associated with it. Okay.
And I think that's where the science is heading. I think just like with any new technology, initially we don't know how to use it. And a lot of the tests we do, we are in that phase, like Signatera, because it's not 100% accurate and sometimes it's inaccurate. I have had patients where the first test is positive and the second test is negative. I've had a patient with another cancer marker called CEA, which was high, and everyone's thinking it's cancer. Well, she has lung fibrosis, and the lung fibrosis apparently makes this number go up. So there's a lot of false positives, false negatives. And I think, like Dr. Shea was saying, you have to follow that up with a scan to show that there's really evidence of disease.
Right, which leads me to ask our radiologist another complicated question. So we have talked about AI in medicine, but radiology has had the most impact of AI in that. So is AI helping you or hurting you?
It's evolving. My group uses it to help with our efficiency. As you know, imaging volumes are going up everywhere, and being efficient is the ultimate goal, to minimize the lag in getting these studies reported to the ordering clinicians. But it is imperfect. Some of the AI that we use, for detecting brain hemorrhages, it sometimes says negative and it's clearly positive. But sometimes it does catch things that are very subtle. So it's like a mixed bag right now. I do want to say that I think clinicians who embrace AI going forward will do better. Will be more optimal for patient care overall than, I guess, clinicians who don't embrace it. I think AI is here to stay, and it has been doing some good things. So and technology is only evolving. So I think clinicians who embrace it in their practice will do better for their patients than those who may not embrace it.
Okay, so one of the things that's become clear is that for a cancer disease process, right, we are doing way better on our treatments than we have ever done before. So then people develop recurrent disease, people develop metastatic disease, things like that. The Society of Radiation Oncology gave a bunch of different stratifications of stage 4 disease. So stage 4 disease can be a little stage 4 disease or a lot of stage 4 disease. So Dr. Rajasekar, can you talk about that a little bit?
Yeah. So we have this concept of progressive disease, where disease is getting worse, a recurrent disease, where a disease is gone and it comes back. And I think what you're alluding to is oligoprogressive disease, where the cancer is mostly under control, everything is gone, but there's one site of cancer somewhere that's growing. Oligo is single, progressive, progressing. So one area of disease is progressing. Sometimes there's oligo recurrence, where recurrence just happens in one spot that's localized to where the cancer is removed from. And our treatments really change depending on what kind of progression that is. Someone might have colon cancer that's come back in the liver, but they have oligo progression, where they just have one part of the liver that's showing evidence of progression. And in those patients, typically we used to do chemotherapy and give them chemo and give them months of chemotherapy to see that tumor shrink. And now what we do is more localized therapies in some of these patients, because because it's our experience, and there's clinical trial research to back it, that sometimes when there's oligo progression, where there's only one side of disease, you treat it with radiation or targeted radio frequency ablation or surgery, and these patients did not need chemotherapy, and the cancer never comes back. So that's where the science is evolving, and that's where all these newer technologies are helping us take care of patients. I just want to highlight this: the only field of science that I know where the people who practice it are actively trying to lessen the work we do and bring less business to that industry is healthcare. Like every trial we do is like, how do we reduce the amount of chemotherapy this patient takes? It's counterintuitive to me, as if you think of it as a business, but what we actually care about is what's right for the patient. Like bring down, when we used to do chemo or surgery, mastectomy, we barely ever do mastectomy now because we don't want people to be disfigured. And I think that's where the science always keeps heading.
Right. So one of the things that El Camino has purchased recently, which is coming in August, is something called histotripsy. And histotripsy, so we have a lot of tools for, and I'm just going to call liver masses for the sake of simplicity. So for liver masses, you can give chemotherapy, you can give radiation, you can do surgery, you can do a local ablation, you can do other types of treatment depending on location, size, multiple places that it is. But the newest is this focused ultrasound, and that's histotripsy. And so histotripsy means that you can eliminate lesions based on focused ultrasound of sorts. And it's one of the newest tools in the armamentarium of taking care of liver lesions. And the newer indications are for liver lesions, some indications for kidney tumors, some indications for pancreas tumors are all coming out. And the reason patients really like this is because it doesn't even leave you a little nick in the skin, right? It's all based from outside directed in. So it adds to our ability to deal with this progressive disease in a way that sicker patients, you don't have to come off chemotherapy, all of this stuff. And so Dr. Lai is anxiously awaiting the indication for kidney tumors.
I think it's exciting because not only it's transdermal surgery, right? So you're not making any incisions. Through the skin, you're focusing ultrasound waves to ablate the kidney tumor. And there's also studies ongoing to say, when you do that, do you actually increase the immune response for the body so that it decreases cancer coming back, cancer recurrence. So it is very exciting.
Yeah. So I recently went to a class about this, and so I too am anxiously waiting it arriving at El Camino, because I think, and one of the things about new technology that the previous panel described a little bit is that we have to work through the indications. We have to work through our clinicians have to get together and make sure that that is the right tool to be using for that job. And the more tools we have, the harder the discussions are. So let's talk a little bit about tumor board, okay? How many tumor boards do we have a week?
Three that I know of.
Oh, 3. Okay. And so who goes to tumor board?
All of us, right?
Yeah. All of us, and pathology and social work and everybody, because it's a team sport. Cancer treatment's a team sport. And so what kinds of patients do we discuss at tumor board?
I discuss all my patients at tumor board.
Why?
Because I think it's beneficial, even if it's an upfront straight case, to have consensus and making sure we're reviewing the latest literature, latest guidelines for all of our patients.
I see. And what else? So within tumor board, do we discuss clinical trials? Do we discuss social work stuff?
Every tumor board starts off with an individual patient case, but it's always a good starting point to talk about what did we learn at our latest conference, the latest papers that came out, ASCO guidelines, NCCN guidelines. And so, every case presented is unique, and we take into consideration the patient's particular disease, staging, and their lifestyle considerations and what they prioritize, and we make a personalized recommendation based on that.
Yeah. And so we present at tumor board, our case conferences, our newly diagnosed patients. We discuss recurrent patients. We discuss rare patients, all of these things that come up for people. And I think what's really important about this conversation is how, some things are cut and dried, right? They're by guidelines and stuff. but not every one of the patients and the cases fit into guidelines very well, or they have travel issues and such and such. So it becomes nuanced, and the patients don't, and the caregivers don't always see all the discussion that goes into things, but we do discuss. How did the GYN oncologist do this sort of thing?
We have a separate tumor board as well. So we have a couple. We have one. We travel to multiple hospitals in my group. So usually each hospital has their hospital specific tumor board where we can present stuff because the pathologist and the radiologist are also hospital specific. But then we also have a GYN oncology only multidisciplinary tumor board with GYN pathology, like a special radiologist that dials in, and then GYN oncologists from here, the city, Berkeley, and Sacramento and Davis. And we all get together to discuss mostly our very complicated cases where it may not be straightforward what to choose next as therapy.
I see. Okay. Well, we have reached the end of our session. I appreciate you guys' attention. I appreciate the panelists for their candid discussions about the complicated nature of our care and really emphasizing for us what multidisciplinary care looks like. So thank you so much. We are very fortunate to have volunteers and people that want to come and support our cancer patients in any way. The idea that you can come and help a cancer patient get through their day, whatever little thing you can do to brighten their day, is critically important.
My reason for being there is interacting with the patients, and I think I do a successful job of getting them to smile and to laugh. Because they're not there to be laughing and smiling. And I know that from family members that have been through it. My husband died from cancer, and that might have been something that inspired me to help.
Connie Maritini is a heart of gold. She's been a volunteer of the Cancer Center at El Camino Health for 20 years. And that commitment and enthusiasm is just remarkable.
Sometimes it's a little bit of the cart that the volunteers walk around the cancer center with, a bit of a story, hey, how are you doing? That's not a clinical voice. It's a look, it's a reassuring person that is there just for you.
5 or 6 years ago, I introduced a Virgin Bloody Mary. It's just a little can of V8 juice. And there isn't a male that has said, no, thank you. And I thought, oh, am I a flight attendant or something? But what I really do enjoy doing is interacting with each patient.
Without our volunteers, we will be missing the community in the clinical setting because they're the ones that bridge that connection.
I spend a fair amount of time in each patient's little space where they're getting their infusions. I get to really know them, and we talk about other things. We don't talk about cancer because I know that they have cancer, and they're there for oncology treatments and all. So we become almost friends, really.
So Connie, first off, I'd like to thank you for your service, for your dedicated time to our cancer program. Every week for 20 years is a remarkable achievement. You bring to the cancer program your warmth, and that is reflected in each and every one of our patients. And so, again, I thank you for taking the time out of your day to spend it with our patients.
Connie, thank you so much for your fabulous 20 years of service. You have brought so much joy to the Cancer Center and to me. Really, you are truly a wonderful person, volunteer, and my friend that I really cherish. Thank you, Connie.
It's very meaningful to me to interact with a cancer patient. I know that there's more in life than just cancer, and I want to make sure that I can help give them what else there is in life.
Big birds, so swift and good. Your flower, bird is so big, I cap her. All right, Luna, look at the camera right there. Boy, there, very good now. Yep, exactly. Yes. And so I thank you so much for your service. You brighten the day of all of us. Okay. Cool. This does it. Okay. Am I supposed to talk? No. On this screen, if you want to say anything else, we're going here. You could have Yeah. Thank you. Oh yeah.
It has been a real delight working with El Camino Health and all the staff there that have been there a long time, too. That's the quality of the staff. And meeting the patients, I feel like they're all my friends. I truly, when I see people, and we've had cancer in our family, but it's good. It's really good. We don't talk politics and we don't talk cancer. So people can understand that. But it's truly an excellent hospital. And I'm so excited about what they're coming up with. And I know my last child was born there. He works here. The hospital's so good. I jokingly said he hasn't gone far in life by that, but that's not a good joke. So my other son also is in medical, and my two daughters. Almost all my grandchildren have been born here. This is a good place to be, and I'm so impressed with the staff. And when I do try to meet with each patient, unless they're sound asleep, we really have fun chatting and talking about other things in life. And that really is important to get beyond what cancer can be. And we have a wonderful time. I've even had patients say to me, they ask when I'm there, and it's always on Wednesday afternoons. And so they try to get their appointments for Wednesday afternoon just so we can chat and have maybe tea or coffee, because they have a good coffee machine there now in the cancer center. And we really have a very meaningful time. And some of them, it's been years. So we have become very good friends. And I love it. I would pay. Well, I sort of pay El Camino by donating, but I'd pay to let me volunteer. It's so important to me every Wednesday. So thank you very much.
Hello, everyone. Thank you for staying. This is coming to the end of our event. And my name is Nicole. I'm the Oncology Dietitian with the Cancer Center. Today I'm going to be talking all about protein. If you visited my table, you may have gotten some handouts. There are still some left. And also, after I speak for about 20 minutes, we're going to get a cooking demo. So make sure you stay for that as well. So I had to show this picture because I was at the grocery store recently and I saw this whole aisle full of protein supplements. You may have seen this too if you're in various grocery stores. But there are protein powders, protein drinks. Protein is very much at the forefront right now. So this is very evident. Many companies are also branding their products as having added protein. So you may see these as well when you're in the grocery store. When I think about protein, I think about building muscle, and I also think about foods that are naturally high in protein. So these are the ones listed here. Things like beans and legumes, nuts, chicken, fish, and eggs, dairy foods. So these are all high protein foods on their own. And I'm going to put a question out there to the audience. There are 3 breakfast meals here, so take a look. They're labeled 1, 2, and 3 on the bottom. Which of these do you think has the most protein? Just hold up your fingers. 1, 2, or 3. 2 over here, 3, 3, 2, 2, 3s and 2s over there. Okay, very good. So let's do the big reveal. Number 3 is the highest protein content, so it wasn't a trick question. Eggs are an animal protein, and 2 large eggs is about 14 grams of protein. And so if you had some eggs, an egg omelet, it's going to give you more protein, although oats in the middle are considered more of a high protein grain. If you added some milk, if you added some seeds, you would get more protein. And then the cereal, of course, most of the protein comes from the milk. So which of these meals is the easiest to prepare? Number 1, right? Cereal, of course. So just keep that in mind. If you're trying to eat more protein, there might be more effort that goes into it because you have to maybe do a few more steps. So why do we need protein? I'm not going to bore you with all of these reasons, but there are many reasons. Every cell in the body requires protein. So you need protein to build muscle, build and repair muscle and other tissues, transport nutrients, support blood sugar, bone density, energy production, hair, skin, and nails, fluid balance, and then fighting infections, supporting the immune system as well. So here's another question for the audience. When we talk about muscle, at what age does muscle loss start? What do you think? 50, someone said? 40? 40? Someone said 30? Yeah. So the answer is 30. Yeah. Starting at age 30, adults lose 3 to 5% of muscle mass every 10 years. So 30 to 40, 40 to 50, 50 to 60, and then this accelerates, unfortunately, after age 65. So even more so. And why is this a concern? Because too much muscle loss can lead to decreased strength and mobility and increased risk of falls, which we don't want to happen. So specifically, if you're going through cancer treatment, protein is important to support your recovery between treatments, rebuild cells and tissues if you've had surgery, chemo, or radiation, preserve muscle mass. That's the one I always highlight with my patients. Oops, sorry. Support the immune system, and then help to maintain your weight during treatment. So let's talk a little bit more about how much protein is in certain foods. So if it's a packaged food, you can look at the label right there in bold. It says protein and it's listed in grams. And then make sure you look at the top at the serving size as well, because that's the amount of protein in that serving. And if you came to my table, you probably saw this handout. So these are both animal and plant-based protein sources. And you can see there on the right, it'll tell you how many grams of protein. And then in the middle there are the portion sizes. And some of these are still available on my table if you want to grab some on the way out. And then there's also, if you don't eat animal foods, there's also a handout that's specifically about plant-based foods and high protein sources. So legumes and soy foods, grains, seeds, nuts, these are all high protein foods. What you may have heard is that some plant-based protein foods may not be complete. They may not have all the essential components that your body needs. So what you can do is pair them together. So if you have a whole grain, you can pair it with a legume. So these are the examples: brown rice with beans, whole grain bread with peanut butter, whole grain pita bread with hummus, because hummus is made from garbanzo beans, barley and lentil soup. You can also do this with a whole grain and nuts or seeds. So the example being oats with nuts. You could also do nut butters, whole grain pasta with pine nuts, whole grain tortilla. You could even do a whole grain muffin with chia or poppy seeds, and then whole grain bread with pumpkin seeds or sunflower seeds. So you pair them together to create a complete protein. So this is what everyone wants to know. How much protein should I have in a day? This is a complex topic because you have to take many things into consideration. Someone's age, their gender, their height, their weight, how active they are, what's their overall health status. So I'm talking very generally today about how much protein you should have because it's very individualized. So we're going to look at this in two different ways. Bear with me. We're going to do a little bit of math. So keep that in mind, okay? So the first way is we're going to think about protein as one of three macronutrients. So there's fat, protein, and carbs. All of these provide calories, but they're not needed in equal amounts. So majority of our calories come from carbohydrate, and there's a range you can see there. So if someone has diabetes, they might have carbohydrate closer to that lower end of 45%. There's also fat needed in a certain percentage, and then protein, 10 to 35% of all of your calories would come from protein. So for the example I'm going to use the number, I'm going to use 20%, so kind of right in the middle of that range. So let's say someone needs to eat 1,500 calories. So we're going to take 1,500, multiply it by 0.2 because we're talking about 20% of calories from protein. That gives you 300 calories. We need to do a little bit more math. 300 divided by 4 gives you 75 grams because we want to get to grams. 75 grams of protein is 20% of your total calories if you're eating 1,500 calories. So what if you are asking, well, how do I know how many calories I need? So what you could do is use one of these two apps, MyFitnessPal or Chronometer. You can enter in your information, your age, your height, your weight, and it will kind of estimate how many calories you need. This isn't 100% accurate all the time, but it will give you a good number. And then you can also enter in the foods that you eat. It will tell you if you met your calorie and your protein goals. Does anyone use any of those apps or have you heard of them before? Okay, good. Yeah, very helpful. All right, so that was the first way you could figure out how much protein you need. The second way is using this number, 0.8. This is called the recommended dietary allowance. So this is grams per kilogram. Most Americans are used to using pounds, right? So how do we get to kilograms? We're going to take your weight, divide it by 2.2, and that gives you your weight in kilograms. So 150 pounds, divide that by 2.2, that gives you 68 kilograms. And then you're going to multiply that by 0.8. And that comes out to 55 grams per day. So this is 0.8 is considered kind of a minimum number. So basically this would be your protein needs, but you could always go above that if needed. So like I mentioned, the RDA is 0.8 grams per kilogram. But let's think about athletes, right? They need more protein. They are building muscle. They are very active. So that number actually increases to 1.2 to 2. Cancer patients also need more protein in a range of 1 to 1.5 grams per kilogram. If someone is experiencing cancer cachexia, so significant muscle loss, they might need greater than 1.5 grams per kilogram. If someone has kidney disease, you actually want to go a little bit below that 0.8, and this is specifically kidney disease not on dialysis, whereas if someone is on dialysis, they might need 1.2 grams per kilogram or greater. So if you hear anyone talk about protein on social media, the recommendation I'm seeing and hearing is 1 gram per pound. So that means if you're 150 pounds, they're telling you to eat 150 grams of protein. If we use the grams per kilogram, that's 2.2 grams per kilogram, which is even more than what's recommended for athletes. So that's really high. I don't think that's an acceptable range for most people. And if you've heard of the dietary guidelines, these come out every 5 years. The newer guidelines for protein is an increase from that 0.8 now to 1.2 to 1.6 grams per kilogram. So if you go online, if you were looking at the dietary guidelines, these are the guidelines from 2020 to 2025, and then the newer updated guidelines 2025 to 2030. And is anyone familiar with this? Have you seen these guidelines? There was a lot in the news about them. If you go to the protein section of the guidelines, it shows you here protein serving goals 1.2 to 1.6, like I mentioned. So this is the first time the recommendations have increased, and they've increased pretty significantly. But there's also a little note here about making sure you adjust based on your individual needs, because this isn't a one-size-fits-all. So let's use another example. If you're 150 pounds, divide that by 2.2 to get kilograms, just like we did before. Now we're going to multiply it by 1.2 to 1.6, and that gives us a range of protein of 82 to 109 grams of protein per day. So someone who's 150 pounds could say, okay, that's a range that I would aim for. But what if someone is 250 pounds and they use the same calculation? Now you can see how much higher those protein like the daily protein would be, 136 to 181 grams. It's really hard for someone to eat that much protein. So what you could do, if your BMI is greater than 25 or if it's greater than 30, you could actually figure out what your weight would be if your BMI was at 25, and then use that weight and multiply it by 1.2 to 1.6. So you're not getting these excessive high numbers. And overall, it's best to work with your dietitian, right? To come up with how much protein you need, because again, this isn't a one size fits all. All right, we got through the math. Hopefully that gives you a better idea of how much protein you might need. And this handout is also at my table. So let's talk about how you can meet your daily protein needs. The research is showing it's best to spread your protein out during the day. So this shows you 3 meals, each providing about 30 grams of protein. I have this handout at my table, if I didn't say that already. So this shows you like an omelet for breakfast, a chicken soup that contains beans and whole grains, and then for dinner would be some fish tacos with beans and cheese. If you follow a plant-based diet, no animal foods, this is another example of how you could spread your protein out. So 15 grams at breakfast, 25 at lunch, and 25 at dinner. This would give you about 65 grams for the day. Notice the stir fry for dinner has a lot of high protein plant-based foods. Cashews, edamame beans, pumpkin seeds, brown rice. So you definitely want to make sure you get a good variety of those. That's just protein. That's just showing you protein. Yeah. You shouldn't. Yeah, if that meets your daily protein needs, because some people need more protein, some people need less, so you can adjust as needed. So during cancer treatment, there are some side effects that could affect someone's protein intake. Some people experience decreased appetite, maybe aversion to meat or eggs, taste changes, aversion to food textures. So some things you could do are try smaller, more frequent meals, more high protein plant-based foods. Again, pair your protein foods, those plant-based protein foods together to make a complete protein. And you could always add in protein powders or protein drinks, which I'll talk more about in a minute. And if you did do smaller, more frequent meals, you could do snacks in between and smaller portions. This example here would give you 75 to 80 grams of protein in a day. So this is how you could meet your protein goals if they were up that high. Another thing to notice about this and the previous meals, there's lots of color, right? So you're not only getting protein, you're getting vegetables and fruits and healthy fats. So you're getting vitamins and minerals and fiber as well. So all of these other things that are needed for a healthy diet. And it's all about balance. If you ate too much protein, which I think is being recommended sometimes, it can hinder your intake of those other food groups that I just mentioned. So you may not be focusing enough on the vegetables, the fruits, the whole grains, the legumes, the healthy fats, and you might be missing out on other nutrients if you're eating just protein. So let's talk real quickly about protein powders. As you saw in the picture I showed, there are many out there that are available to buy. They're convenient. They can easily be added to water or milk. So if you're not getting enough protein from your food, this would be another option, way to get more protein. Look for minimal ingredients because sometimes there's a huge long list of ingredients. There could be a concern for lead. I've seen this specifically with plant-based protein powders. Sometimes they're tested and they have lead in them because it could be that the soil that the plant was grown in had lead in it. So look for a company that uses a third-party verification. That way their ingredients are being tested and verified. One other thing to think about if you're going through treatment, protein powders are high protein, but they're not necessarily high in calories. It's going to be a low-calorie option. So you could add the protein powder to a smoothie to increase the calories. Another option, if you needed more calories, is to use an already made nutritional supplement. So some examples are Ensure, Boost, or Gain. These come in both milk and plant-based options. And let's not forget about exercise, because when we're talking about eating protein, making sure you're maintaining muscle, avoiding muscle loss, we have to exercise as well. So in addition to your moderate aerobic exercise, which is like cardio, you want to make sure you add in at least 2 days of muscle strengthening exercise per week. Does anybody do any of these things that are shown? Walking, lifting weights, yoga? Good. So 2 days a week is definitely a good goal. We're going to get into some questions. We have 5 minutes of question and answer time. And then we have a very special cooking demo that's going to be happening. So if anyone in the audience has questions, there will be microphones going around. So you can just let me know. And I know we also have a virtual audience, so we could take some questions there as well. There's one over there. Oh, and one over here too.
Okay. For the beginning stages of multiple myeloma, what would be your dietary recommendations?
There's no specific diet. I actually have a handout on my table that goes through just healthy guidelines while you're going through treatment. So there's no specific, diet per se, but fruits and vegetables, whole grains, healthy fats, limiting processed meats, limiting added sugars. Those are the guidelines.
We have.
Thank you very much. This is a great presentation. It's very helpful and reinforcing. Is there any downside to too much protein metabolically? I know you mentioned the danger of maybe not eating enough of the other foods, but in terms of what happens biochemically, is there any downside to too much protein?
Yeah, there can be long term. So eating too much protein, specifically animal proteins, could be a strain on the kidneys because the kidneys help to filter out any toxins, and they're helping to eliminate those, but they're working hard. And so basically it could be a strain on the kidneys if you're eating too much protein. There's water involved in that as well. So it could be that that's also dehydrating that whole process. Also, another thing to keep in mind is if you're eating too much of any of the macronutrients, it could cause weight gain. So because you're getting too many calories per se. Yes.
We're gonna take one from the live stream before we come back to the room. Hello to everybody who's joined us online. One of the questions that we got was, with 75 grams of protein, can we eat as much? What does that mean in terms of carbohydrate and fat intake? Can we up that intake as well to align with a higher protein diet?
Yeah, so I focused today on protein, especially with those meal examples. But yeah, you would want that when I showed in the beginning that pie chart that had carbohydrate, fat, and protein in certain percentages, you would kind of want to balance those out. So if you had 20% of calories from protein, then maybe you could do 50% from carbohydrate, and then what's left, 30% from fat. Yes. She'll bring the mic over.
You mentioned about walking can help to improve our protein. So I just want to find out, walking, brisk walk, shopping mall walk, or what type of walk that benefits more to get our protein?
So whatever you can tolerate best. One thing I've heard of is if you're walking with a friend and you're talking and you're able to talk easily, that's a good pace. If you're not able to talk because you're too out of breath, maybe that's too much. So just kind of what's best for you. But really, walking is considered a weight-bearing exercise. So paired with protein, that's going to help to build muscle and maintain muscle.
Great. Thank you.
Yeah.
We have another question from the internet.
Sure.
Can you tell, a lot of the protein recommendations that you made are dairy based, and wondering if you have any particular recommendations or thoughts to share about upping that dairy intake so much. Is that a concern, and how can we address that?
My mic just went out. Oh, there it goes. The guidelines are for 3 servings of dairy foods per day. So if you're not exceeding that, then that's fine. So if you had half a cup of yogurt, if you had half a cup of cottage cheese, if you had a small serving of regular cheese. So yeah, you wouldn't be eating too much dairy. And in addition, you can definitely focus, if you don't want to eat all dairy, you can definitely focus on those plant-based sources that I talked about, and I have a handout for those specifically as well. Okay. No more questions for the room. We can take one more virtually if there's any. Okay. Is there one more?
Excuse.
Yeah, the whole time.
Thank you for your presentation. If you think I eat not enough protein, maybe my body will get weak.
That is a risk. Yeah. So protein helps to maintain muscle mass and bone mass. And so it helps to prevent weakness. Yeah, exactly. So that's why it's recommended, especially like I said, as we age. I mentioned muscle, but also at the age of 40, we start to lose bone mass. So it's important to try to maintain both of those. Thank you so much. Oh, is there one more?
Are there any protein powders you recommend?
I have some at my table if you'd like to come over there. Yeah, there's so many. It's hard to really narrow it down, but we can talk about that. Yeah. So this is the recipe. Everyone will get to take this recipe home. There should be a recipe card in your bag. This is a quinoa and kale salad. Like I said, we have a very special treat. We have Chef Jacques here today. He's going to be going through how to make this recipe. Quinoa is considered a high protein grain. It's actually technically a seed, but we say it's a grain. And then there's garbanzo beans. And if you wanted to add a side of tofu or chicken or salmon, you could do that as well to increase the protein content. So let's bring Chef Jacques.
I'll have to fix my pay up. I have a mic on here. Oh, son. I gotta be careful what I say now. Well, you can look at that picture there, and it's a little bit, I was younger. I had a little bit more hair on my head anyways, and a little chunky there. But I've been at El Camino for almost 17 years now, and I've been talking about quinoa for probably 24. And I think people still pronounce quinoa, right? It's not quinoa, it's quinoa. I know there's comedians out there that talk about quinoa and that sort of thing. A couple things out there. You can buy pre-cooked quinoa and save time, but it doesn't take that long to make quinoa. The same with couscous, which is another nice alternative. The difference is some brands of quinoa has less protein than couscous. Like this couscous brand has more. Couscous, you put water or stock, you let it sit, it's done. Quinoa, you have to cook. Okay, so look at your grains and different things on the shelf in the grocery store to figure out what's going to work with your lifestyle. Food prepping is huge. You know, if you start on a Sunday and work through Wednesday, you can have a lot of things done already. And basically, you make let's say a pound of quinoa. Then you have quinoa for one day, second day, and third day you put it in the freezer for the next time. So food prep and meal prep is a big part of my life, because I live so far away. So I want to make sure I'm eating the right amount of proteins, grains, and vegetables daily. I'm one of the few chefs that have their own personal garden at home and eat from garden to table. Yeah, and you know, this did not come from my garden, but we grow vegetables such as these in my garden. So I'm not really cooking today. I'm doing a demonstration, a real simple demonstration. Sometimes people say it's simple for a chef, but not for me. Well, Nicole, when her presentation, I'm telling you right now, she does more math than I do. My math is simple. Cups and teaspoons or tablespoons. Okay. So the vinaigrette here is just one that we made it more so a vegan. And so if you try the recipe outside, it says we did use agave opposed to honey. So the entire recipe outside is, if you get a chance to try that, is using agave. Agave is a little bit more expensive than honey, but at the same time is plant-based, okay? And that's what we're using today. If you prefer to make your own salad dressing or use anything that's out there, be careful of the sodium, be careful of the sugar out there. When you control the narrative to anything you make from scratch, you control your calories, and calories is really important. So we just add a little bit of agave, and I'm not measuring because I'm not. Because it's, you know, I had my team put this together, and so like any chef, we're going to put it together. We're not going to really taste it, but it's made perfectly out front. Before I go on, I'd like to thank my team that's here today. Gina, Kat, Roy, and Ramon. Giving them a big hand. They prepared everything you had today, from the overnight oats, the bran muffins, the quinoa salad, etc. They put it all together. So the recipe on that overnight oatmeal was amazing today with the chia seeds in there. Anyway, so we're going to take a little bit of mustard. That's a little bit, that's good. A little bit of oil. Little pepper. Now, once again, sodium and control the narrative. If you have sodium and you cook your kale and your quinoa in the broth, you look at the sodium, it may have enough for it. You always have to taste at things. And what we're going to do here is just going to massage the kale. Why did the quinoa get embarrassed? It saw the kale undressing. What did the quinoa say to the hot dog? You're all buns, but I'm full of grains. So anyways, it's Saturday. So by adding the dressing to the kale, you're gonna soften it. And one of the ways you can soften it is exactly what I'm doing. You take your salad dressing, just massage and break down the fibers. And that's exactly what I'm doing. And I can tell you right now, this is gonna taste really good because of the mustard that's in here, and the lemon juice, and the salt, pepper, and olive oil, and your own dressings. You wanna break it down enough, okay? What's that? No, it's raw. So if you're going to use spinach, collard greens, Swiss chard, any of those leafy vegetables, it's going to break down in the salad dressing. And now we're just going to add some quinoa. And I know the recipe only mentions one type of pepper, but you know, you add more color to your food, you really enjoy it more. I mean, if you just had just quinoa on a plate, you may look at it and say, I'll get to it later. But if you add colors to your food, you're really going to look like you enjoy it more, okay? So all we're doing is mixing all these things together. And this will keep up to one day. I wouldn't push it beyond that because what happens, your kale starts breaking down and starts deteriorating. Once again, a lot of these different things you can find pre-cut in the store, but if you have time, do it yourself. You save money, and you can use your other products with different things. We have fresh mint here. You can do basil. You can do thyme, coriander, whatever your herb of choice is. When you're looking at your beans, such as we're using garbanzo beans today, they were dried garbanzo. I'm going to say that 3 times. Garbanzo, thank you. We use dried, and when you use dried beans, you control the narrative of how much sodium you put in that. In the store, there are a lot of cans that say low sodium or lower sodium, but look at the back and read your labels. Kidney beans, navy beans, black beans, all great proteins that you can add to like your salad here. So here we go. Here, the salad is. If I had a tasting spoon, Gene, I forgot to give me a tasting spoon, but I'm not going to blame Gina because I should have looked. So, your salad. I'm going to add more quinoa because it is a quinoa salad. Why did the quinoa start a bakery? Because it needed a fresh start. Okay. Like I said, it's Saturday. So, in all lessons, we're done. That is your quinoa salad, okay? So, the biggest thing is food prep. Obviously, I didn't come in this morning and chop. I know on TV you see chefs chopping and for the action and everything, but in order to do this for real, I would have chopped a lot of these things ahead of time, and I would have planned my meal for the next 3 days. Tomorrow, my wife and I will start looking at what we're going to have for the week. Chicken, beef, pork, whatever. We take one protein and we split it up or we put it in the freezer for the next week. You make a lasagna, you do turkey lasagna, you do a lentil. We had a lentil and a lentil lasagna the other day, and then I made lentil soup. So, I mean, you gotta just take your proteins, you take your fruits and vegetables so you don't put them all in the refrigerator. There's 2 of us at home. We rather see the refrigerator slightly bare than overabundant of food because we know we can't consume it all. So just what I'm saying is shop smarter. I know we have a minute or so left. Any quick questions? Any quick questions? We need a new photo, I will tell you that much. Yeah. Well, I want to just say thank you all for being up. Oh, got a question in the corner.
If I'm a little bit sensitive to kale, would it be okay to steam it a little bit, or would it get too soft?
Well, if you were going to use kale, I just drop it in the water and pull it out. You know, and collard greens, it's the same thing because they're really hard fibrous greens. But spinach, I would just toss it right in. But if you look at the salad, I mean, it's breaking down quite a bit. So if you started this in the morning or if it's the next day, it's going to be broken down. The fibers will be broken down quite a bit.
Are you going to be auctioning off that bowl there?
I will auction myself off for the hospital if you want to make a donation. So I want to thank you all for being here. I know Saturday, once again, and I mean, great thing about Saturday, there's virtually no traffic. You know, so but that's all I got. Thank you. Okay.
So before we conclude, first of all, thank you, Chef Jock. and Nicole. Great job, right? Give them another round of applause. So before we conclude, we have a few people we'd like to thank for making this day possible. It's a long list, so please hold your applause and we'll give everyone a big round at the end. So first, we want to thank the El Camino Health Foundation for sponsoring this event and so many initiatives within the cancer service line. I know that one of the questions that we had online was, how are we sponsoring so much innovation at El Camino Health? It's actually thanks to the foundation efforts. We have a strong foundation partner with El Camino Health, and really so much of what we do, purchasing equipment, providing services, putting programs together, all of it comes from foundation fund. So I know you all have a brochure in your bag for a circle of giving. So please feel free to take a look at it. And there's an opportunity to donate to the foundation if you'd like. Another thank you goes to our speakers, panelists, physicians at the Ask the Doctor tables, vendors, partners, community programs, and vendors and partners who supported us in planning and executing this event, as well as all the volunteers you saw throughout the day. We also want to thank all of our staff, the Oncology Service Line team, and our colleagues across El Camino Health for all of your hard work preparing for this event. Special kudos to our Oncology360 Planning Committee for contributing your ideas, time, and effort to make this day a reality. And of course, we're also thankful for you all being here. I know it's been a long day. We try to feed you as well as we could. To show our appreciation, additionally, we have a few last things for you. First, let's give out these raffle prizes. We have 2 certificates for acupuncture to give away, valued at $195 each, thanks to Hope Neuroacupuncture Rehab. We want your feedback. Your insights help us continue to improve on this event. Please scan the QR code on the screen. And for those who are joining online, click on the link in the chat and take a few minutes to tell us how we did. We hope you're leaving today with new ideas and resources that will serve you. We're committed to the highest standards of care to anyone who walks through our door, and we're actively thinking about how to do that in the best possible way every day. And what better way to provide that care than with food? Please feel free to take one last walk around the tables outside and enjoy the snack waiting for you in the lobby. And thank you all so much. I hope you have a great rest of the weekend.